welcome to the Central District Board of Health agenda for Friday, December 17th, 2021. It is 8:30 a.m. I am the presiding chair representing Elmore County. Betty Ann Nettleton is my name. I represent this county along with Representative Megan Blanksma. To start the meeting this morning, we'll have a call to order by county, starting with Ada County. Dr. Young.
Jane Young here.
Raul Labrador.
Raul Labrador here.
Dr. Cole. I don't hear anything. Boise County, Commissioner Sturm. Elmore County, Representative Megan Blanksma.
Representative Blanksma here.
Valley County, Commissioner Hasbrook.
Commissioner Hasbrook, present.
Okay, thank you, folks. Proceeding on with our agenda under action items, I'll turn discussion over to Director Duke. I believe there are some changes to the agenda. So, Russ, go ahead.
Sure, thank you, Madam Chair. So we did make one change to the agenda that was published and posted, but it will require a vote, a motion and a vote from the board if you will allow item number 8 to be included. It's a discussion and vote on board designated operational reserve funds to be used to implement the Nurse Family Partnership Program, and I'll be the one to present that. And that is the only change that I am requesting.
Okay, thank you, Russ. Do you wish to have that motion now or wait till we're at that point in the agenda?
I think let's go ahead with the motion now so the full agenda, new agenda will be approved before we get started.
Okay. I will entertain that motion at this time.
Madam Chair, this is Commissioner Hasbrook.
Yes, go ahead, El.
I'll make the motion that we approve the new agenda item, including item number 8.
Thank you. Is there a second to that motion?
This is Jane. I'll second it.
Okay, thank you, Jane. Any further discussion before calling for a vote by county? Well, hearing none, we'll go ahead, starting with Dr. Young, Ada County.
Jane Young, aye.
Raul Labrador.
Yes.
Dr. Cole. Boise County, Commissioner Sturm. Elmore County, Representative Blanksma.
Blanksma, aye.
Valley County, Commissioner Hasbrook.
Hasbrook, aye.
Okay, thank you, folks. That motion does pass. Thank you. Russ, did you have any further comments before we move on to new business?
I don't.
Okay, thank you. Okay, moving on to new business, we need to vote for our November 17th approval of our minutes. At this time, are there any corrections or additions to those minutes? If not, I would like a motion to approve those.
Madam Chair,
Hearing none, go ahead.
I was just going to move to approve.
Okay, thank you, Jane. Is there a second?
This is El. I'll second.
Okay, thank you, El. Okay, thank you. We've already asked for any corrections or discussions, so we'll go ahead and call for a vote. Ada County, Dr. Young.
Young, aye.
Raul Labrador.
Aye.
Dr. Cole. Boise County, Commissioner Sturm. Elmore County, Representative Blanksma.
Blanksma, aye.
Valley County, Commissioner Hasbrook.
Hasbrook, aye.
Okay, thank you, folks. Those minutes do stand approved as presented. Moving on, we'll have a discussion by our guest, Dr. Christine Hahn, who is the Medical Director for the Division of Public Health and State Epidemiologist, and Dr. Kenny Bramwell, who is System Medical Director for St. Luke's Children's Hospital. And Russ, I would like you to take the discussion over and introduce our guests at this point.
Sure. Thank you, Madam Chair. I really appreciate Dr. Hahn, Dr. Bramwell being here with us today. I know there's hardly two busier people in the whole state of Idaho right now for certain. And I want to just first say I invited them because there are a lot of questions out there right now as far as pediatric vaccines with the 5 to 11-year-olds being approved at the end of October, 1st of November, as well as booster doses, questions about the impact on the pediatric population from COVID infections. And then also we now have a new variant in Idaho, Omicron, and we'll see how that plays out over the next few weeks and next few months. And I've also asked Dr. Hahn, specifically given her role, to give us some ideas of what this might look like down the road. We've been dealing with it for coming up on 2 years, and there appears to be no end in sight. So first, I'll introduce Dr. Hahn. She'll speak to you first. Dr. Hahn attended medical school at Michigan State University, completed a residency in internal medicine at the Mayo Clinic's Graduate School of Medicine, and a fellowship in infectious diseases at Duke University Medical Center. She then completed a fellowship in CDC's Epidemic Intelligence Service, and she now serves as Idaho State Epidemiologist and Medical Director in Idaho's Division of Public Health. She is board certified in infectious diseases and serves as the medical director of the state TB program. So I'll go ahead and have Dr. Hahn speak, and then I'll introduce Dr. Bramwell. Thanks, Dr. Hahn.
Thank you. Can you hear me okay?
Absolutely. Thank you.
Yes.
Great. And you can see my slides?
We can.
Okay, perfect. Thank you, everybody. And thank you for inviting me to update today. I know you have an incredibly full agenda, so I will try to go fast. So I apologize if it seems like I'm rushed, but I'll go through quickly, and hopefully after Dr. Bramwell's presentation, we have a little time for questions. And if not, totally understand. We can be reached later. So I wanted to first quick talk about statewide trends. I know you have your staff coming on, Russ, to talk about what's happening in the district. Some of the tools we're using, education, vaccines, some really interesting, exciting news about therapeutics coming up, which are going to be even more important as we talk about Omicron and expect it to see more cases of Omicron in the state. So first of all, on the left-hand side there, you can see the trends in the United States have unfortunately started climbing again. And right now, on a weekly basis, 249 cases per 100,000 population in the United States, so higher than it was looking several weeks ago. However, in Idaho, on the right, you can see we continue. We're worried that our declines have maybe kind of stalled out, but we haven't seen an uptick yet. We're hopeful, but not optimistic, I guess is what I would say. We're concerned with the holidays. We'll talk about that later. But right now, we are actually a lower rate than the national average, with our case numbers continuing, again, to be kind of steady is how I'll put it. And again, you'll hear from the district later about what's happening more locally. I wanted to just point out on the far right, you'll see, I just pulled this off the CDC site yesterday. So if you look at where Idaho is right now and really the Northwest, we're looking pretty good, relatively speaking. The increases that have been reported and that are driving those national numbers have mostly been in the some in the Southwest, but also in the upper Midwest. You heard from Russ. I'm from Michigan, so I'm always very interested in kind of what's happening there. That part of the state, that part of the country, has been definitely seeing some increases, and you've heard a lot about their hospitals starting to become overwhelmed. And then, of course, the Northeast as well. But you look back just a month ago, and it's a really different picture. It was much more center of the country, looking very concerning. And then you look back another month, and Idaho was 4th in the nation. So it's, I just want to point out, it is changing constantly, and we are not able to fully predict yet. We'd like to. We want to have answers. We like to feel like we have answers. We don't always have answers. We can only use the best data to try to help predict what might happen. Our percent positivity, for those of you that follow that, that the percent of people that go in and get tested and actually turn out to have COVID is actually a really reliable indicator of how the virus is spreading in the state and how much burden we have. And you can see here that we've kind of been dropping really since September. Our percent positivity had peaked late September, and actually started to drop, and we've kind of stabilized, if you will, over the last 4 weeks or so at about, 5 weeks, I'll say, at about 6 to 7%. We are concerned. We would have liked to see it go lower. The goal has always been fewer than 5% positive, but to kind of show that that virus is kind of under control or not spreading very much. But that's where we're at right now. So actually a much better place than we were a few months ago. We continue to see, though, of course, people in the hospitals. You're all very well aware of our recent crisis standards of care that fortunately this part of the state is no longer operating under, but continue to see people hospitalized and dying from COVID. The majority of them not vaccinated, but we do see some vaccinated people that also have severe outcomes, mostly, but not all. People who are elderly, they tend to have a higher rate of breakthrough. And of course, as time goes on, since they've had their vaccination, we know that the vaccine effectiveness decreases over time. So we believe we're starting to see more of that. And I know Dr. Bramwell can speak more clearly to what he's seeing in the hospital now, if you want to talk about that some more. So I want to focus on just the Idaho's response. I'll kind of keep it at the state level. You guys hear regular, I know, from the district staff about what the Central District Health is doing. I don't mean to ignore all the hard work being done at the district level, but I'm here to kind of talk more about what we're doing at the state level. I think most of you are very familiar, or hopefully are familiar with the dashboard and the governor's site, coronavirus.idaho.gov, that you can get vaccine data there on the top, that blue bar on the top, get our latest vaccine data, and then towards the bottom, statewide numbers, the dashboard there for cases, deaths, et cetera, are all updated daily on those sites. In addition, and the whole thing wouldn't fit on one page, so I just pulled over at the bottom of that front page. You can see our constant reminders to people that we do recommend things like getting your vaccine or your booster, wearing face coverings, staying home if you're sick, washing your hands, et cetera.
Do you want to take this stuff?
And I'm sorry, I'm hearing some background noise. I don't know if someone has a hot mic there. If you wouldn't mind muting. Thank you. So education, again, I put these 3 screenshots up to remind me to mention, we continue to do, for a while we were doing weekly media briefings. Right now they're every other week, but we want to continue to be available to the media so we can answer questions. They get a lot of questions from the public. We just held one on the 14th, so just a couple days ago, this past Tuesday. And for this last one, we focused on long-term care facilities and some of the challenges there. We had Dr. Megan Dunay come on, who is a geriatrician and very knowledgeable, and it was very useful, I think, to really focus on that population. Remind people, if you're going to go visit your loved one during the holidays or have them come visit you in your home and they live in a long-term care, ideally, hopefully they've had their booster shots and you're all vaccinated, and making sure you're protecting that vulnerable Idahoan. We also try to use social media. I am definitely old enough to not be a natural at it, but thank God we have people that can do all this very well, sending regular tweets out and messages. There's a blog that you'll see on the right, a recent blog post, where we tried to focus on obesity. I hear over and over again from doctors that so many of the folks in the hospital, the severely ill, are overweight or obese, and that's just a very delicate discussion and topic, and we don't want to fat shame anyone, but we need to point out that folks that are overweight or obese, especially those who are morbidly obese, really need to take care of themselves and protect themselves. Again, they tend to have very, very severe outcomes, not just seen in Idaho, but in other places around the country. So we released a blog on that topic recently. Here's a slide, just an example of what we recently presented at the media briefing. Again, looking at from various facilities around the state, our skilled nursing facilities, of which there are about 80 right now. How many of them have, what % of their population? They report this to the feds, and then we're able to just download that information. Just how many of them have gotten their folks boosted that are eligible for a booster? Of course, some may not be eligible, some may decline it, but it's important for us. And then we are reaching out to those facilities that haven't. You'll see on the left-hand side, some facilities are saying none of them. So our immunization staff then reaches out and sees if they just need help. Sometimes they just need help identifying a vaccine provider that can come into their facility and provide those vaccines. So we're trying to make sure they have that opportunity. We're actually doing better than the national average on this metric, though. So we're really pleased with how things are going, but we need to keep working, make sure everyone gets boosted if they agree. So this is our vaccine data by day, and you can see In orange, those are folks getting a third dose. So most of those are booster doses. Some of them might be immunocompromised people who require 3 doses as part of their primary series, but you can see third doses have really picked up since the recommendations came out. We're really glad about that. A lot of those are seniors, as we've been talking about in long-term care, but also in the community. Those are the folks who are at highest risk if they maybe go into the holidays without having had a recent booster. This is just showing kind of over time how our vaccination rates are going in adults, and you can see here early high uptake, a lot of mass clinics, a lot of activity, and then it sort of flattened out. But I take heart that there are Idahoans, and you can see that on the last slide. I didn't point it out, but we continue every day to have some people that initiate the series that think about it for a while and say, yeah, I'm going to go and get vaccinated now. Maybe they want to travel. A lot of folks end up getting the vaccine because they need it to travel, but to get on the airplane or to get to another country. But we also are looking at kids now. As kids start, parents are considering whether to have their kids vaccinated. You can see there that we're at about 41% of kids in this age group, 12 to 17, have had at least a single dose. And we are working with pediatricians just to make sure they have information to counsel their patients. You can see it varies a lot around the state. No news to everyone. We see really the highest rates have been in Blaine County and continue to be so, but you can see how this is by zip code, so even a little bit of a different look, and you can go on our site that I pointed out previously and look at this in a little more detail if you're interested. So of course we understand that there's just a ton of work. We get a ton of questions. I know you do too, about safety of vaccine, risks of vaccine versus the risks from COVID. And I just wanted to, it's too big of a topic obviously to tackle right now, but I participate in the Advisory Committee on Immunization Practices meetings. We just had one yesterday, and they have presentations from the VAST group, which is a group of physicians and other experts in vaccines and infectious diseases looking at safety data. The Vaccine Safety Data Link, which has those medical centers highlighted there in the lower left. Also, VSafe, those of you that have had a vaccine know that you have the option to have an app where you report any vaccinee can report any side effect through this app. I did it myself and I thought it was quite handy and easy to use. You get a daily reminder, do you want to report anything? And then of course the Advisory Committee on Immunization Practice meeting, which tries to put that all together and include those in their recommendations, and that just have their website there. This is an example, and one of the things that we talked about yesterday, this slide was shown yesterday, is the different types of vaccines have different risks. And this slide just points out that the Janssen vaccine, which was discussed yesterday, is less effective against COVID compared to the RNA vaccines, the Pfizer and the Moderna, in every age group, really. And so yesterday, and this is just from the Washington Post, but yesterday the advisory committee met, and after discussing Johnson & Johnson, and there have been 9 deaths reported due to this rare blood clot issue, they changed the recommendation to say that the Pfizer and Moderna vaccines are preferred over the Johnson & Johnson. Not only the lower effectiveness, but the risks just outweigh. They didn't completely vote to not recommend the vaccine because some patients may still prefer it. For example, certain age groups don't tend to have this problem. And so they left it available, but just said that for most patients, the Pfizer-Moderna vaccine is a better choice. And of course, I like this graphic, but I wanted to show it real quick. This is from nature.com, and they have a really nice graphic just talking about all the questions that are being grappled with about boosters, which groups need them, what's the optional timing, the optimal timing. And of course, now, okay, so now you've had your booster, how long is that going to last? And that is just not known yet. It is not clear. Clearly, these vaccines we hoped would be more like the measles vaccine, where you get a long-term protection from them. It is not panning out that way, and it is likely that either additional boosters will be needed down the road, or they need to develop new vaccines that are more durable and provide a broader protection against respiratory coronaviruses. So obviously a work in progress, but these are some of the questions continue to be grappled with. I wanted to leave a little time for therapeutics. I will not go through this slide, but just to let everybody know that once somebody's in the hospital, this is where Dr. Bramwell and other physicians that work in the hospital take over. But in public health, we've been very actively working on this side of the equation, if you will. First of all, of course, vaccines to prevent illness, but I'm going to talk a little bit about a new monoclonal antibody that I'm very excited about that I think is going to be incredibly helpful for some of our vulnerable population. We have monoclonal antibodies, of course, for people who have been exposed to COVID or who are actually already ill with COVID. The governor has committed quite a bit of funding to help ensure this around the state, and we have other providers who are doing that as part of their clinical practice, and these are very helpful. In addition, we will soon have some outpatient oral antiviral medications available, which we're hopeful will be very helpful. So I'll talk a little bit about those now. So another way of looking at this real quickly is that this area is where some new and exciting therapies are coming along for people who either don't respond to the vaccine, can't respond to the vaccine, or have already gotten ill. So this one, EvieSheld, just was authorized by the FDA, and this is for pre-exposure prophylaxis. So the way I think of this is, for those of you that remember, when you used to travel to a developing country, you'd get the gamma globulin shot in the butt kind of thing before you travel. And so you weren't sick, but you were getting antibodies ahead of time in case you got exposed to hepatitis A, a common foodborne illness, especially in developing countries. This is that same sort of idea. So this is given, it's a combination of two long-acting monoclonal antibodies. They've already shown at least 6 months of protection, and they think it might be up to 12 months of protection from getting one of these shots, or I should say 2 of them, because you get 2 separate shots. And this is unfortunately right now only in very limited supply, and it's going to be prioritized for, and I've been to discussion, we are on federal calls with HHS, but also with our neighbor states. We're going to focus all on chemotherapy patients, and transplant patients. And in addition, make it available to people who have other severe immune deficiencies. So those are folks that even if they go out and get vaccinated, are not expected to have very good protection. We are expecting only, for example, they say once this is available, we'll get maybe 300, enough to treat 300 people initially, very limited, nothing like what we hope we will eventually see. But we have already reached out to cancer treatment centers all around the state to get them enrolled in this program so that as soon as it's available, we can get this out to them to give to their cancer patients. And we've also told them that we expect them to be willing to treat patients referred into them from, for example, patients who are transplant recipients. So lastly, Omicron. This is from the New York Times site, just showing kind of the countries that have already documented local transmission of Omicron. And then these are countries that have reported it, but apparently so far at least are only reporting it in travelers, but you can see clearly becoming prevalent around the globe. This is from the CDC site this morning, showing which states have reported cases, of course, including Idaho, as you're well aware. And you probably heard earlier this week that CDC is now estimating about 3% of transmission in the United States right now is Omicron. This was presented yesterday, and I grabbed it from that meeting, that ACIP meeting, CDC meeting. You can see here in the United Kingdom, this is just comparing how quickly Delta rose back when it became predominant, which was much faster than we had seen with previous or other variants, and showing how quickly Omicron has jumped, even appearing at a more rapid trajectory than Delta even. This is from the United Kingdom. So last slide, I just want to say, and I'm sure you've heard this, but so much is not known, and I think we have to be very careful not to overstate our confidence. But data from the United Kingdom and elsewhere suggests that Omicron could dominate in the US eventually, but it is unclear if or how it'll affect hospitalization rates. You may have heard, I heard this morning on NPR, University of Texas has just released some estimates. And of course, the media jumps to the most worrisome scenario, which is their job to tell us how bad things might be. But I've looked and I can't find that data yet online. Texas looked at 16 possible scenarios. There's so much not known. But they said at the most optimistic scenario, they still do expect an increase. It's not going to, I'd love to think that in Idaho, things are going to keep going down, but it doesn't appear that way. And I think Omicron will probably contribute to some sort of a bump or another surge. How big it is probably the biggest question. We don't know yet how well masking and social distancing will work for Omicron, even though the transmission suggests more transmission. It's not clear yet whether how protective, I should say, masks and distancing and all that will be. That is obviously a huge question, and that needs to be watched very carefully. Vaccines, you've probably already heard that lab studies looking at antibodies in the lab suggest that vaccines are less effective against infection, but still are expected to maintain good protection against severe illness. Some of the early data is looking promising, but not as good. You probably heard, I think it was yesterday, the news came out that the vaccines might be as low as 30% against infection, but still provide maybe 70% protection against hospitalization. And that with boosters, at least in the lab, antibodies level rise to the point where they can neutralize Omicron in the lab setting. Epi is always the final answer on that. What actually happens? People previously infected with other variants are less protected against Omicron in South Africa and the United Kingdom. So even though natural immunity can provide some protection, especially against the same variant, it appears that there's also some concern that Omicron is going to escape that immune system either way, whether you got a vaccine or whether you've been previously infected. Unfortunately, the monoclonal antibodies also don't appear to be like they will work as well. With sotrovimab, one of the monoclonal antibodies may be an exception to that. In the lab, that looked good. We do have that as a possibility to start distributing that more widely if that is the case. And then lastly, one good bright spot is that antiviral medications that are coming down the pike are expected to maintain their benefit against Omicron. So I will leave it at that, and I apologize for talking fast and probably just whisking over stuff, but thank you very much.
Thank you, Dr. Hahn.
Thank you, Dr. Hahn. Are there any questions for Dr. Hahn at this time?
I have a question.
Yes, go ahead, Raul.
Madam Chair, thank you. Dr. Hahn, I just want to be clear on Omicron. What we know right now is that the cases are not that severe, correct? And that it's more like a severe cold. I just want to make sure that we're not spreading fear to the public, because we keep hearing, even the word itself, Omicron, seems like really scary. It seems like a really scary thing. And right now, everything we know about this is that it's not as severe. It does seem to infect people more rapidly, but the results have not been as grave as, for example, the Delta variant and other things.
Yes, so the early data does suggest that it is less severe, especially from South Africa. I think the thing to recall is that this is why, you hate to say it, but we need to wait till we see how it acts in the United States. But for example, in South Africa, they've had different variants circulating, so their base immunity is a little different. Their vaccination rate is lower. They had a younger, healthier population to start with, right? It started in this university students, so they're not probably going to get a severe disease anyway, but you're absolutely right. Early indications are that it's less severe, but the way I try to think of it is if you have twice as many people get sick and half as many of them end up in the hospital, you still end up with the same amount of people eventually in the hospital. So yes, we're less worried about its effect on individual young healthy people who will probably be fine, but the community effect, if a lot of people get sick, some of those will end up in the hospital, and we could end up overburdening our hospitals again.
And one more question, Madam Chair.
Yes, go ahead, Raul.
And my understanding is that even in South Africa, where it started, they have decided not to introduce any new restrictions or anything. They've decided that it's not severe enough to go into a panic mode and do anything more severe than they already were doing?
Yeah, Raul, that's a good question. I must admit, I'm not quite sure what all South Africa's doing. I do know in Europe, of course, they've introduced some new restrictions. So every country is probably going to react differently to this, depending on what they fear. I did look yesterday at hospitalization rates, and so far, at least in South Africa, they haven't seen an increase or in the United Kingdom. But what the fear is as this becomes more prevalent, we might be looking at increased hospitalization down the road. So every country's got to do that calculation.
Thank you.
Madam Chair, Dr. Cole, can I comment real quick?
Yes, Dr. Cole, go ahead.
I agree with Dr. Hahn, and to answer Raul's question real quick, I've been on the phone with several colleagues in South Africa over the last couple of days, and it is not behaving any more aggressively per se. Dr. Hahn's absolutely correct, and they haven't seen any increase in oxygen requirements per se, hospitalizations per se, and no uptick in adverse outcomes, gratefully. So it does appear with the mutations being so far different and this being genetically so far different and not branching off the other variants that we've experienced so far, this is basically its own genetic tree, much more similar to the original Wuhan strain. It appears to be much more mild, and my colleagues in South Africa have been able to manage it actually more easily in the conversations I've had with them than they have with the previous variants. So thank you.
Thank you, Dr. Cole.
Madam Chair, this is Al.
Yes, El, go ahead.
Yeah, Dr. Hahn, I have a question. This is what, the third or fourth variant coming out. Are we going to see another one after this, or where do you think this is going to end?
Yeah, thank you for that question. And Russ Duke did say in the beginning that he had asked me to kind of, I think most of us expect we will continue to see variants. As Dr. Cole mentioned, Omicron is its own animal. There's been at least one paper published suggesting it might have been like a recombination event with another coronavirus. But what we know is this is it's a virus that is rapidly mutating, and I think we will see more variants. It's just a matter. That's why I think there was a very good editorial yesterday in the New England Journal of Medicine suggesting that we really need a universal coronavirus vaccine. Our current vaccines are not going to, we can't vaccinate ourselves out of this with the current vaccines or programs. We need more solutions down the road that are going to be more broadly and more durable protection.
Thank you.
Mm-hmm.
Dr. Hahn, this is Betty Ann. I'd like to just hear you comment on what we may face as Omicron infectious rate continues to climb and the influenza vaccine doesn't look at this point to be as effective as we'd hoped, and what that collision may look like this winter.
Yeah, thank you, Betty Ann. I would say it's too early to say how well the vaccine's going to do. I heard a little discussion about influenza before the meeting started. We've only had a few detections of influenza so far in Idaho and across the nation. There hasn't been enough to really have a good flavor for how well the vaccine's doing in the United States. That said, even and getting back to Dr. Cole's point, let's say Omicron is a lot milder. We are worried if we have flu and corona and COVID going on at the same time that the winter is going to be tough on our hospitals. I know Dr. Bramwell can address that. But the hospitals, even though we're out of crisis standards of care, they are still, we are on a daily call with the hospitals, and they are still stressed. They're still, they still feel like they're full. They still feel like they're, barely making it kind of thing as far as their staffing and their ability to handle this. So we're really worried about a winter increase. Not to mention RSV and is still circulating. It's another respiratory virus. We have other respiratory viruses that are circulating that we are worried are going to come together. I know we sound like we're always predicting doom, but we want to make sure that we are warning people of the possibility without, to Raul's point, we don't want to alarm or frighten people. We want people to feel like they've got the tools to deal with this. If this comes, they know what to do and that they feel like they're protected by some of the advice that we're giving them.
Okay, thank you.
Mm-hmm.
Further questions for Dr. Hahn or comments? Okay, well, thank you so much, Dr. Hahn. And hearing none, we'll move on to Dr. Bramwell's presentation.
Betty Ann,
Thank you.
may I give
Yes, Russ, you may.
Okay, thank you. I introduced Dr. Hahn. So Dr. Bramwell, he currently serves as St. Luke's System Medical Director for St. Luke's Children's Hospital and Children's Service Line. In addition to his leadership position, Dr. Bramwell is clinically trained in and practices both pediatric emergency medicine and emergency medicine within St. Luke's Health System, caring for both children and adults. Dr. Bramwell is a fellow of the American Academy of Emergency Medicine, the American Academy of Pediatrics, and the American College of Emergency Physicians. In addition, he is a member of the American Association for Physician Leadership and the American College of Healthcare Executives. Dr. Bramwell has practiced medicine for over 20 years. He earned his doctorate degree from the University of California, San Diego, and his bachelor's degree from Brigham Young University. So welcome, Dr. Bramwell, and the floor is yours.
Thank you, Russ. Thank you for the background, and thank you, Dr. Hahn, for the really great presentation. We'll go ahead and go to the next slide. So I wanted to paint the picture of sort of some of the numbers that I think are relevant. When I say children, I'm referring to patients who are ages 0 through 17. Once you hit 18, you're an adult, though sometimes that's a gray line, not a very perfectly clear line. But using those numbers or those ages, children represent about 17% of the COVID positive patients, and that's all comers. That's patients who are at home, patients who are not necessarily ill enough to be in the hospital. So that's all comers. So they're they're just about on par with the percentage that they represent. They are between 1.7 and 4.0% of the COVID positive admissions, and they represent between 0 and 0.27% of the fatalities from COVID. Some of these numbers are perfectly fixed, like the 17.2, and these others are ranges based on the 46 states that are submitting data. And you can see the sources for those data points in the citation below. I will comment here that until the Delta variant came along, children were only 10% of the COVID positive patients and about half that number of admissions. So Delta has been a big problem for children. There have been some children's hospitals throughout the country which were unable to accommodate patients and having to send them out of state. We had to do that here, but that was because of RSV over the summer. So the Delta variant has been somewhat unkind to children, maybe disproportionately so. Let's go ahead and go to the next slide. So this is now commenting on the admissions we see here. As Russ mentioned, I practice, but my main job, 80% of my time is spent as the System Medical Director for St. Luke's Children's, but I also do a few ER shifts each week. I will tell you that every single COVID admission to our children's hospital, I review, and so I'm quite familiar with what we're seeing and what the sort of background of these different patients is. I'll tell you that in the last 18 months, actually we didn't have our first admission until last May, but in the last 18 months there have been 150 children who needed to be admitted here for COVID reasons. Among these children, 30 of them developed MISC, which is Multisystem Inflammatory Syndrome in children, which is the most worrisome complication. That's about 20% of our cases. I guess, to be fair, the most worrisome complication is death, and that has not happened in the 150 patients that we've admitted. We did have a death here regionally in October of an infant, but I don't know any more details about that. We also had one patient out of these 150 who was admitted to the hospital for myocarditis, which I'll talk more about in a bit. So that represents 0.7% of our inpatient cases for COVID within the children's hospital. Next slide, please. Across the board, so this is all ages, the data demonstrate that the COVID-19 vaccines are safe and effective. I will tell you that our local experience, both with the app that Dr. Hahn mentioned, as well as our own patients here, we've been monitoring this really closely. St. Luke's has administered 460,000 doses of these vaccines in the last year. I think today is the 1-year anniversary of when we started. We have used, maybe these are slightly out of order, Benadryl for the mild allergic reactions. We've used that 150 times out of 460,000. And we have used epinephrine one time. Admittedly, these are only the medications that we know about as far as treating anaphylaxis, which is an immediate and severe allergic reaction, which is something that people talk about quite a bit. So we are certainly seeing this, but not to any significant degree. Next slide, please. These are not my words, but these are recommendations from national bodies. We have the American Academy of Pediatrics and the CDC cited here. I'll just read the first one. The AAP recommends COVID-19 vaccination for all children and adolescents 5 years of age and older who do not have contraindications using a COVID-19 vaccine authorized for their use in their age. And the CDC says something quite similarly, or similar to that. CDC recommends everyone ages 5 and older get a COVID-19 vaccine to help protect against COVID-19. So they aren't really mincing words, and they aren't really putting a lot of restrictions in place. So outside of people who have contraindications by the AAP, these folks are encouraged to be vaccinated. Next slide. People talk quite a bit about myocarditis, and they are worried about it. And they say, the reason I'm not getting vaccinated, or I'm not going to vaccinate my child, is because of this risk of myocarditis. Since this is the one that comes up all the time, I thought I would talk about it pretty directly. In adults, myocarditis occurs at a peak rate of 10 cases for every million vaccines. So if 1 million people get this vaccination, 10 people will develop myocarditis. This also occurs in children and in younger adults, probably in the 15 to 25 or 15 to 30 range, depending on how this is broken up in the studies you review. This peaks in that age group. It's more prevalent in males. It's more prevalent with the Moderna vaccine, at least for those above age 18. And it has a range between 40 and 70 patients for every million vaccines given. And I'm citing numbers off of the CDC website and a few slides given recently. I will tell you that myocarditis is sort of a nuisance disease that happens after this vaccine. There have not been any fatalities from this disease nationally. Patients will frequently get admitted. They have chest pain. They may have some shortness of breath associated with the chest pain. They largely have laboratory abnormalities, but they don't have heart dysfunction. They get treated with ibuprofen, and they're in the hospital for a day or two. So it's certainly a real problem, but it is not a long-term problem, and it has not been thus far a fatal problem in anybody. If we could go to the next slide, please. I want to contrast the myocarditis concern with what we see nationally with the risks of COVID illness. So I'm trying to draw your attention to the fact that getting the illness actually has more risks than getting the vaccine. Multisystem inflammatory syndrome in children, or MISC, some people will just say MISC, they'll make a word out of it, which is a little hard. This happens in one case for every 3,000 patients who develop COVID or who test positive for COVID. Not 3,000 admissions, but 3,000 positive tests. This usually happens 4 or 5 weeks after they are sick. In fact, they commonly have a very mild illness. They have a cough and a cold, or they lose taste and smell. And then a month later, they have, well, MISC means multisystem. They frequently have a bad rash. They frequently have abdominal pain, vomiting, and diarrhea. They commonly have pretty significant shortness of breath. They will also have cardiac issues, which we are hopeful that they recover from these cardiac issues, but somewhere between 10 and 20% of the patients with MISC become long-term cardiac patients, which is sort of a travesty in a young child or teenager, certainly. So if you compare the rate of myocarditis with the vaccine, which we said at its highest was 70, the rate of MISC is 333 cases for every million people who get the illness. And the reason this is particularly relevant is I no longer think you can hide I said this over the summer with Delta, and I'm going to say it again with Omicron. Everybody's going to get this. If you're either vaccinated or you get this, or maybe both. But this is so overwhelmingly contagious. I think we just need to be really frank about these risks. The other problem that happens in children, in 7 to 10% of them, is they develop long-term COVID. Sometimes that's brain fog, sometimes that's shortness of breath, sometimes that's persistent loss of taste or smell, which my son said was the worst part of his COVID illness, was not being able to taste for 2 weeks. Sometimes people have chest pain or shortness of breath that doesn't go away for months. We're hopeful, certainly, that this goes away in everybody, but the people who have long-term COVID they didn't die. They commonly didn't need to be admitted to the hospital, but they are sort of walking wounded for a prolonged period of time. Next slide, please. I also want to talk about the Omicron variant. If you want to see what's coming, just look at the Greek alphabet. All of these are Greek letters. I'll save you the trouble of saying this wrong. It's just Omicron, or Omicron, since you live here in Boise. But there's no N at the beginning of the word. You will commonly hear people say Omicron, which is not the right word. It's Omicron. As Dr. Hahn mentioned, this appears to be more contagious than the Delta variant. I've seen numbers cited so far that are between 50 and 200% more contagious than Delta, which is worrisome. As also has been mentioned, this does not seem to be any more serious. In other words, the rates of death don't seem to be higher. The rates of hospitalization don't seem to be higher. But the concerning thing is if 2 or 4 times the same number of people get the illness, then that's worrisome that 2 or 4 times the number of people will need to be admitted to the hospital, which is a big concern. As you know, we are on crisis standards of care for about 60 days in the fall here. Frankly, I don't think crisis standards of care is a scary enough term for the situation where we found ourselves. I think it should be something that says something along the lines of, oh my gosh, we've run out of ventilators, we're doing the best we can, because we've been using the word crisis for 2 years now. The good news with Omicron is that the vaccinations remain effective at preventing severe illness, in other words, hospitalizations. They don't seem to prevent mild or moderate illness, so that many people will have, upper respiratory infection symptoms of cough and cold and sinus pressure. Next slide, please. So this brings me to a couple of points here that are my opinions, but are also based on national bodies and regional recommendations. I believe that vaccination of children specifically will help individual kids have a lower risk of long-term complications compared to the regular illness. And hopefully I gave you some numbers along those lines. I believe that these individual vaccinations will help prevent additional spread of illness in your family, your friend group, and your community. This is really a regional thing. And then finally, I would suggest thinking of children not primarily as sufferers of COVID-19, but as spreaders of this illness. And by that, I mean people tend to concentrate on the fact that no children, well, until recently, no children, now 1 infant has died from COVID. They say this is not a consequence. Kids can get this, it's no big deal. The challenge is that kids spread this, just like they spread lots of illnesses. And so I want to just have you consider thinking of children, not just in their death rate, but as think of children as productive sharers of this illness with their parents and grandparents. And next slide, please. And I wanted to thank you, first of all, for the stalwart work you've done for the past 2 years and many years before that, but it's been front and center for certainly the last 2 years. And I want to thank you for having me here, and I'm happy to answer any questions at this point.
Okay, so thank you, Dr. Bramwell. The floor is open for questions for Dr. Bramwell.
Dr. Cole, may I ask a question, please?
Yes, go ahead, Dr. Cole.
Thank you, Madam Chair. Hey, thank you, Dr. Bramwell. Appreciate your presentation. Real quick question. I think it's relevant for us just population-wise, as Delta has burned through so quickly in the last several months, and so many people have gotten COVID. Do we have the surveillance on children as to the percentage? I know the floor by the CDC data back in June was 42% of American children had already had COVID. And after Delta burned through so quickly, do we have a good baseline in terms of that natural immunity that's been built up in children across our population now that we've gone through the most spreading variant so far? And I asked that question just in the sense that there are countless studies that show that once one is COVID recovered, to get a vaccine actually increases adverse events. We know the studies from Dr. Hogue out of California showed higher risks of hospitalization from myocarditis in the shot than actually from COVID in the pediatric cohort. So I'm just wondering if we know the percentage, and before we move forward vaccinating children, the concept of screening before vaccine to avert adverse reactions, just wondering if we have a good epidemiologic base for how many children in not only our valley, but in Idaho have had COVID already. Thank you.
Yeah, the best way I can say that is I've not seen any recommendations from national bodies suggesting pre-treatment screening. All of the national recommendations from the AAP and the CDC have suggested vaccinating regardless of recent COVID status. The contraindications to vaccination thus far have included anaphylaxis, or the most severe type of allergic reaction. There's also, and that's an absolute contraindication, and there's a relative contraindication if you've received certain inpatient therapies or antibodies for COVID. So I haven't seen any recommendations of pre-treatment. In fact, I've seen statements on the AAP website that say, even if you've had COVID, we recommend that you get a vaccine.
We've noticed some, thank you, Kenny, or Dr. Bramwell, thank you. And we've noticed in some studies out of the UK where they've actually looked at those who didn't have COVID and got the shot due to original antigenic sin, which is an immunologic concept. We actually narrow the body's ability to make a nucleocapsid antibody response in those individuals that get the shot before they get COVID. And so there's some studies suggesting a narrowing of the ability of the immune response. So I think just from a medical point of view, just from a public health point of view, this is one thing I think we as a community could really focus on. How many kids have had COVID? How many individuals have had COVID? Just because I do believe that, vaccines is a resource, those who do choose to get them and whatnot. Once one's had a good broad natural immunity, all studies seem to be one and done in terms of exposure. It's rare as hen's teeth to get it again if one's had COVID. And again, I am concerned about adverse reactions in children when they've already had COVID. Thank you.
Dr. Bramwell, this is Betty Ann. I know that the virus has been, the Delta particularly, was pretty tough on pregnant women. Are you seeing the offspring of those women having lingering effects as far as, any lung issues or anything, cardiac issues in your NICU?
Madam Chair, Betty Ann, what I'll say is we've had a few thousand births of patients or of mothers who were COVID positive at the time of birth, and we have only had one patient who became positive from COVID. So the transmission of COVID, what we call vertically from mother to fetus before it becomes baby, is exceptionally rare. We have seen, and in fact, the one case that we saw was actually the child probably got the illness in the first week of life from the mom and the dad, who both had COVID and were not really being very careful. And so we think that was actually obtained outside of the mother's body. So not a vertical transmission, but actually a transmission, from breathing. The other question that you asked is, have there been any complications to newborn babies, either in the NICU or in the well baby nursery? And no, we have not seen that, largely because we haven't had any cases but the one that I mentioned that we thought could have been transmitted during the pregnancy. We have had a few dozen newborn patients who have gotten, by newborn I mean in the first month and certainly in the second month, have gotten COVID after being born, and we have not seen cardiac complications with those children. Did that answer the
Okay.
question?
Yes, it does. Thank you very much. Further questions for Dr. Bramwell or Dr. Hahn? I don't know if Dr. Hahn's still on.
Madam Chair, this is Raul.
Yes, Raul, go ahead.
Madam Chair, Dr. Bramwell, I just have a question about your the second slide where it talks about pediatric background statistics. It says that you have between 1.7 and 4.0 of the COVID positive admissions are children 0 to 17. Of those children, how many of them have comorbidities, have other issues other than COVID? Do we know?
That's not reported nationally, but I can tell you that of the 150 patients that we've admitted here, probably about a third of them have other issues. Sometimes these are genetic issues, sometimes these are cardiac anomalies, sometimes they are chronic lung issues or multiple medical problems. We also have a fair number of people who have what I will call incidental COVID, where they didn't come to the hospital because they were having trouble breathing. They came to the hospital because they had appendicitis. In fact, and our first patient a year ago, May, came to the hospital because unfortunately was riding his motorcycle in the dark with no helmet and had a bad head injury and happened to have COVID. So we do have probably about 10% of our patients who have incidental COVID, but are admitted for another reason. But we have not. There aren't. Let me say it a different way. As far as the national data, we do not have a handle on the percentage of comorbidities.
And follow up?
Yes, go ahead, Raul.
Madam Chair, thank you. Dr. Bronwell, so of that 2/3 that you say do not have comorbidities, what is the range of the 150 that you've had in here at your hospital? What is the severity of the symptoms generally?
So the 30 patients who had MISC, that's our most severe group. Many of them ended up in the intensive care unit, or PICU is the acronym that we say. We have had relatively few patients who have been admitted with what I will call acute respiratory COVID.
Okay.
Where they're having chest pain, shortness of breath, and they're on supplemental oxygen or perhaps even a ventilator. That's a very common occurrence in adults, and that's a relatively unusual occurrence in children. Children tend to have more of the MISC than they do the acute respiratory problems.
Thank you.
Okay, thank you, Dr. Bramwell. Any further questions for Dr. Bramwell?
Madam Chair, Dr. Cole, one more question.
Yes, Dr. Cole, go ahead.
Real quick, Dr. Bramwell, on the MISC, I know there are a lot of studies and people know that I bring up vitamin D in the fall and the winter in terms of propensity to different respiratory illnesses. I know there are several studies that associate MISC. Is it a measure that's done in the hospital on these children admitted to see what their vitamin D levels are, as it tends to be an association, not just with COVID, but historically with other coronaviruses, and coronavirus season, MISC has commonly been associated. And it's also been commonly associated, again, correlation is not causation, but a lot of these patients tend to be very vitamin D deficient. I'm just wondering if that's a measure that is measured in this pediatric population when we see them present with MISC. Thank you.
Dr. Cole, Madam Chair.
Yes, go ahead.
I have not seen any of these patients have vitamin D measurements done. I have not seen that recommended by national bodies. So I am not seeing vitamin D as a crucial component or even as an incidental component of inpatient management.
Okay, I'll share some papers. We're friends offline. I'll share. Thank you, Dr. Bramwell. Appreciate it.
Thanks, Ryan.
Okay, thank you. Any further questions? Well, hearing none, I would like to express my appreciation on behalf of the board for all of your hard work and your education this morning. It seems like global education for this whole coronavirus issue has just been crucial. And so once again, thank you so much, and happy holidays to you.
Thank you
very much.
Okay, proceeding on with our agenda. Next, we have in-person public comments, and people who have wishing to speak have a maximum of 3 minutes to testify, and they need to be signed up ahead. So, Russ, I will turn the issue over to you at this time.
Thank you, Madam Chair. We have 8 people that have signed up to provide comments to the board this morning, and we'll just start with the first person and go through number 8. So our first guest is Michael Fish.
And Russ, you will be keeping track of time, correct?
Correct.
Okay, thank you so much. Okay, go ahead, Mr. Fish.
Yeah, I'm Mike Fish, and I'd like to talk about the COVID vaccines for the children ages 5 to 11. So by the CDC, the recovery rate is 99.991% for that age group. I suspect that might be low. Another study out of Germany puts the recovery rate at 99.9993%. I mean, either way, it's the risk in that age group is about as statistically close to zero as you can get. So the question is, why address that at all? And so I looked at the clinical trial document that Pfizer submitted to the FDA for seeking authorization, and I was frankly shocked by what I saw. First of all, as far as the benefit to the kids, they only looked at the antibodies, the titers in the blood, and then made some estimates and extrapolations from other age groups, and reported a benefit there, but there was no direct evidence. In fact, they say here in the document, there were no cases of severe COVID-19 and no MISC reported, and that's in the placebo group and the vaccine group. And so if there was no severe COVID, the question is, well, how do we know the vaccine benefited? And I don't think we do, beyond these assumptions that they made. And also, there were no long-term safety studies done. This is what Pfizer says: long-term safety of COVID-19 vaccine in participants 5 to less than 12 years of age will be studied in 5 post-authorization safety studies, including a 5-year follow-up study. So what we have here is they're seeking authorization, and then they'll do the studies. Then they'll do the safety studies. And that seems entirely backward. 5-year study, by then all the kids will be vaccinated. Then what's the point? I mean, it will have been done, good or bad. And then also, I know Dr. Bronwell talked about the myocarditis issue. The American Heart Association came out with a study that showed 98% of myocarditis in children is caused by these mRNA vaccines, and about 19% require intensive care. And so the question is, in the study, am I already done?
That was 3 minutes, yeah.
Oh my gosh, that went quickly. If I could, the program they admitted in the document was too small to even address that or detect that issue. And so what we have here in these clinical trial documents is no hard evidence of benefit and no meaningful safety studies. And I can't even understand. This doesn't even seem like good science. Why would we take this risk when we don't know? We don't know benefit and we don't know safety. So I guess, I would ask that this board not recommend this vaccine for 5 to 11-year-olds. Thank you.
Fish, comments?
Thank you.
Okay, thank you, Mr. Fish. Next speaker, Russ.
Joanna Russell.
Go ahead, Joanna.
Hi, thank you. At the beginning of this school year, I gave my son's medical mask exemption, written and signed by his doctor, to his school in the Boise School District. Instead of accepting it at that point, I was told I needed to meet with a group from his school to talk about it. I met via Zoom with his principal, nurse, the speech language pathologist from which he receives speech services, his teacher, and the district nurse. I declined to share most of the medical reasons behind his doctor's decision because I wanted to maintain privacy for my son. And there was consensus made between the group that my son would still be required to wear a mask. Them, not being medical doctors, were allowed to decline his medical exemption. This meeting was 5 against 1, and it should have never happened in the first place. I'm telling you this because I want you to be aware of how the Boise School District is interpreting and implementing the recommendations of the CDH. They are denying medical exemptions to students who need them and are making medical decisions for students when they have no right to do so. Thank you.
Thank you. Madam Chair, I have a question.
Yes, who's speaking, please?
This is Raul, sorry.
Okay, Raul, go ahead.
So when they're telling you that they have this mask mandate, are they telling you that they're doing it based on CDH recommendations, or what are you hearing from the school?
During Boise School District board meetings, they confer, they get advice from the CDH and a couple of local doctors. So that's part of the reason why the mandate was put in place.
Thank you.
Yeah.
Thank you.
Okay, thank you. Next speaker, please.
Christine Forbes.
Go ahead, Christine.
My name is Christine Forbes. I'm a mom of both biological and adopted kids and I live in Boise. On December 11th, Central District Health posted an infographic on mental health in the holidays. And the last bullet point said, do what you can to stay healthy by getting vaccinated, a booster if eligible, and by wearing a mask or practicing social distancing where advisable indoors and in crowds. Everyone knows that vaccines are widely available. I could not find any evidence online of masking or social distancing being helpful for mental health. In fact, it's the opposite. I have a friend whose daughter was suicidal in 2019, and she's still with us today because her teacher noticed. Today, if she was masked, her teacher wouldn't have noticed. In the FOSS adopt community, there's a lot of, foster and adopt, there's a lot of kids who can't mask because of PTSD. Some for medical issues, but some because they were forcibly covered when they were raped. These kids are masked every day. Actually, these kids aren't. These kids are mostly homeschooled. They're in online school. They're in private programs. They're in charters. The kids that I'm really worried about are the ones who haven't been caught yet. They're forcibly covered at night, and then they go to school where they're still forcibly covered. And how can they learn? How can they still be? How can they get help? It's the same at home, at school. So I'm really concerned, and I've tried with Boise School District, and they rely on you guys. They say we have to listen to their recommendations, and they don't even let us talk to them. I almost feel like I'm covered there. So I would ask that you remove your mask recommendations for schools based on the availability of vaccines, level of natural immunity in the community, availability of prophylactics, and low hospital and mortality rates for kids.
I have a question, Madam Chair.
Yes, Raul, go ahead.
When you're talking about mental issues for these kids, you're not just talking about suicidal ideation. You're talking about many other mental, because I think there
Yes.
seems to be a misunderstanding every time I've asked a question about mental health issues caused by masking and this pandemic. The answer to me is always, well, there's not suicidal ideation that has increased, which I disagree with, but it doesn't matter. That's not really the question that I'm asking. I'm asking about mental and social health issues that are being caused by these masks. Is that what you're talking about?
Yeah. I'm talking about kids who have PTSD, and so when they cover, then they're reminded of what happened to them. I'm talking about kids who have anxiety, and something about the way that the covering happens increases their anxiety. Things like that.
Thank you.
Thank you.
Thank you very much.
Okay, thank you so much. Next presenter, please.
Lori Ered.
Okay, Lori, go ahead.
Thank you. My name is Lori Arrett, and I'm the mother to an elementary school student in the BSD. I have been very outspoken with the BSD against their mandating of masks. I've provided written testimony, articles, studies, and photos. Some of these I provided to you via email on Wednesday. I'm here to speak on a personal toll this mask is taking on our children. Masking is unsanitary. My daughter has sensory processing disorder and will only tolerate cloth masks. She wears a clean mask each day with spares at school because she can't stand the feeling she constantly rubs her face, her nose. These are clean masks. Note the staining. This is a sample of what many kids have pressed against their faces for 7 to 8 hours a day. It's abuse. The doctors with St. Al's and St. Luke's, who tout their ability to wear a mask all day without issue, are doing so in a hospital setting where the environments are sterile and they're changing them constantly. Students are not in sterile environments. They're not changing their masks often, if at all. They're wearing dirty masks and inhaling disgusting germs every time they take a breath. During recess, they wear their masks on their wrists, under their chins, in their pockets, where they then pick up even more filth and germs. They then put these same disgusting petri dishes right back on their faces for another few hours. Germs that are then inhaled, bacteria and viruses that are sitting in their nasal passages, should be expelled during exhalation, sneezing, or coughing, are sent into their masks like a catcher's mitt, and then re-inhaled back into their lungs, causing infections. How many children, especially younger ones, remove their masks to cough, sneeze, or rub their nose? None. Especially not my daughter. According to the NIH, during the 1918 influenza pandemic, the majority of deaths were caused by bacterial pneumonia, meaning that the bacteria living in the nasal cavities was not being expelled and instead breathed into the lungs. They wore masks. As a mother, I would never intentionally rub a filthy cloth against my daughter's face repeatedly, but the CDH is suggesting just that. It's abuse. Your recommendations to the BSD to keep their mandate in place is indirectly causing health issues. You're being negligent in your role as a public health agency. You may not agree with my stance on optional masking, but you should agree that a parent knows what's best for their child. I don't tell you what medical decisions to make for your families. Don't tell me what ones to make for mine. My child, my choice. Thank you.
Okay, thank you, Lori. Next presenter, please, Russ.
Brooke Torres.
Thanks for having me. My name is Dr. Brooke Torres. I'm a practicing chiropractor here in Boise for over the last 22 years. And you might know chiropractors have primary licensure, full physician status, hospital privileges, primary care, and our licensure. I have a little handout I gave you. I'm going to kind of stick to it and skip past, and I'll just so you can follow along. But yeah, I've been reading research, personally performed and documented hundreds and hundreds of exams on adults and children over the last 2 years with a specific focus on masks and on the function of people's health. Based on this work, I've developed concerns about the mask due to a number of issues, such as negative health changes, mask efficacy, and emotional burden. I'll highlight some of the data here, but mostly I like to skip to my experience. Interestingly, this number 2 point regarding around cerebral hemodynamics, ultimately, it's really complex medical language. I know some of you could understand it, but the idea is that when it comes to human physiology, it's a really complex issue, and it's not one size fits all medicine, which mask recommendations are. And it's just make no mistake, it is a medical recommendation. And coming from medical agencies, they're not looking out for individuals' health, and this is where medical exemptions would be powerful for kids. I can skip on down to point 6, some of the other comments here, but your face has 43 facial muscles, all designed for expression and communication, verbal and nonverbal, and covering a child's face mutes nonverbal communication. It can result in, strange emotionless interactions, and it's really hard for them to bond in a school environment. But down to 7, I personally examined over 200 children in the local school districts. I mean, that's more cases I found out than we've even had of COVID in the hospitals from Dr. Bramwell. So I was really surprised to learn a lot of the issues are way worse than I ever expected. And I didn't know this until I started interviewing these kids. But in the testing, I evaluate and document over 15 different criteria, including psychological, neurological, physiological, and biomechanical, and stress response tests that are quantifiable measurements with and without a mask. Though the results of some children are much more dramatic than others, all have a negative effect on their physical and psychological outcomes on a majority of the criteria that I test with the mask involved with children. I've learned a lot from these kids about wearing their masks at school. I certainly wasn't expecting to find a lot of it. Children who've never had a nosebleed in their entire life have nosebleed every single night since they started wearing a mask at school. It's the only cause. Kids who used to like school no longer want to go or hate going, varying levels of anxiety from severe to mild, and related to getting in trouble due to their mask rules and varying from teacher to teacher, depression, difficulty breathing, skin irritation, acne, sinus congestion, sore throats, repeated sickness when typically healthy, kids learning how to cheat the system, defy teachers and break rules simply just to, not have to wear their mask. I don't think that's a good example. Multiple times I've heard kids say that they just simply can't read because their brain isn't working when they have a mask on. I just wasn't expecting to hear that. But this is what's happening. I mean, I'm interviewing, I'm talking to these kids. This isn't a hypothesis, this is the result of this policy. And I can measure these outcomes. They're not desirable, they're unhealthy, and I know in certain terms, I feel they're dangerous for kids. To be clear, if you haven't spent any real time in the schools and watched how it works and how the schools function, or spoken to hundreds and hundreds of these kids, then it's hard to make this policy sensible. But kids take off the masks all the time. The schools have varying level of strictness, how they enforce the rule. It's adding a massive level of distraction, negative attitude from students. And to make it worse, I've examined severe asthmatic children who are unable to get exemptions from their pulmonologists. Yes, I have one more. Okay, thanks. I've spoken to these parents in detail about these issues. I've even spoken to their specialist physicians and surgeons. And ultimately, they're fearful of backlash, and someone won't write an exemption. So we're handicapping doctors from being able to help patients at the same time. And I think that your policies are important in guiding the ability of these students and the doctors to perform these functions. So at minimum, from a practical standpoint, I think that masks are controversial. There's at least as much information or more showing that they're unhealthy and damaging versus that they might help. And making masks optional, or at minimum allowing health exemptions, is a rational way to move forward. Thanks for your time and attention. That's all I have.
Thank you for your comments.
Thank you so much. Okay, Russ, next speaker.
Crystal Erickson.
Okay, Crystal, go ahead.
Hello, my name is Crystal Erickson. I'm a parent to 3 kids in the local school district, Boise School District here. Also, early literacy education. I teach at an online school, and I'm just here to request that the CDH take away their recommendation for masks for children in school, because that's what Boise School District is following right now. Because I just simply ask that parents have the option to either opt out of wearing a mask, to get a medical exemption. Right now, Boise School District is not allowing either one of those options and are masking our kids all day long. And I've heard doctors say that, oh, it has no effect. You know, there's no research to effect. Just being a mother of 3 kids, I can take the research that I see from them every day, and it is affecting them. I had kids who loved school, and right now their love for school is diminishing. I have a child who plays in 5th grade band. They are required to wear a special band mask that the school provided them, never told the parents about. I finally kind of figured it out. I took that band mask out of his instrument case, washed it, and if I could show you the picture, the water's black. So I sent a picture to the school and just said, hey, you might want to let other parents know that these masks are in their case. You know, I have no communication that I was instructed to wash it. This is what the water looked. The water was black. I was responded with, okay, we will let them know. So thankfully our principal at least did. And the teacher then sent an email explaining that it's probably just dye. But to know that it is recommended that kids wash their clothes before they wear them because the dye, the formaldehyde on their bodies is not healthy. To know that he was blowing in and out of his mouth with this mask on, and to see the black water come after washing that mask, it was disgusting. And it breaks my heart that they have to deal with that. I also talked to a 5th grade teacher there at the school, just asking how things are going. She said it's great that the year is more normal than before, but she is extremely exhausted at the end of the day with her mask on all day long, that these kids will say something across the room and she can't hear them. She said, it's so hard to hear them, their mask on. So sometimes I just go, oh, So to think that these poor teachers can't hear a student, a poor student can't even be heard, and they're just like, who even knows what that student has said? So simply just asking that we take into consideration that masks are not a one size fits all for all students, that parents should have the choice, students should have the choice. We're not asking to take away choice to wear a mask. By all means, give that right, but give right to the students who are really suffering in a mask all day long.
Okay, thank you for your presentation. Next speaker, please, Russ.
Sandy Carden.
Before I leave, I'm going to present the board with the testimony of a woman who was prevented entry today for not wearing a mask. I only have one copy. It was what she was planning to read. So if I may, before I leave, thank you. My name is Sandy Carden. I would like to speak to some of the information CDH has recently provided regarding school COVID guidelines. At the October CDH board meeting, 2 studies, the Arizona study and the 520 county study, were referenced to justify the current COVID school recommendations, which are being turned into mandates by some school districts. There are major problems and shortcomings with both studies, including but not limited to. Both were written roughly 2 months after the guidance was released, thus giving suspicion that they were cherry-picked to affirm a predetermined conclusion. Presumably, other counties could have been chosen to show an inconclusive or opposite result. The studies did not account for other factors, such as ventilation upgrades, time spent with open doors or windows, or time spent outdoors. The Arizona study concludes that schools without mask mandates have a 3.5 times higher chance of a COVID outbreak than schools with mask mandates. But an outbreak is defined as 2 positive cases in a 2-week period, and I do not believe that the study specifies that transmission must occur at school. The 520 county study specifically lists the following limitations at the end. Causation cannot be inferred, and these findings might not be generalizable. But CDC and CDH are using this study in a way that infers causation and makes the findings generalizable. During the November 9th pediatric vaccine presentation by CDH, parents were urged to vaccinate their children so that herd immunity could be reached and we could return to normal schooling. Most of the districts around the state were learning in person last year, many without masks, social distancing, or quarantine for most or all of the school year. Currently, only 3 out of 167 public school districts have strict COVID mandates. School closures this year have been rare, brief, and often not COVID related. Vaccine breakthrough cases are too high to continue justifying widespread vaccination as a means for herd immunity. Even states with very high vaccination rates, such as Vermont, are experiencing a COVID surge. Children continue to be at low risk for complication with or without being vaccinated. People can make their own medical decisions, and our kids' education should not be used to influence those decisions. As Dr. Bramwell previously stated in this meeting, everyone will probably get COVID. So why do we keep focusing on trying to prevent transmission? Finally, I would like to express concern over the meetings occurring between CDH employees and school district employees that are not open to the public. I've contacted the CDH attorney on 4 separate occasions with no response over this issue. Since these meetings are closed to the public, there's no way to know if CDH is just recommending and the districts are turning those recommendations into the mandates on their own volition, or if they're being pressured into creating mandates by CDH. Either way, CDH recommendations are being turned into mandates, which are causing harm from prolonged masking, excluding students and staff, many of whom are healthy, from the classroom, instilling fear into and creating division between students, staff, and parents with a minimal difference in spread and no way to quantify the reduction in the number of cases, hospitalizations, or death. In fact, according to a public records request I obtained from CDH, no records are kept on adults who have been hospitalized or died from COVID who are directly infected by a child. So these recommendations turned mandates are placing a large burden of responsibility on the population least affected by the virus, least able to advocate for themselves, causing short and long-term harm with no quantifiable benefit. Thank you.
Comments. I have a question.
Yes, go ahead,
Sure
Raul.
this is Raul. Have you seen, just yesterday, the Atlantic came out with a story that says the CDC's flawed case for wearing masks in schools. Have you seen that?
It's just yesterday. No, I'm familiar with the articles, but I'm not familiar with them.
Okay. I would recommend everybody on the board to read this. And I think it goes to the issue that you're raising, that we're using a study that is being found more and more by people to be flawed. These are experts, not conservative activists like myself or parents like you. These are experts that are looking at these studies and saying that it was flawed, that they didn't use proper data, they didn't use proper methodology. And one of the quotes from one of the experts in this article is, "You can't learn anything about the effects of school mask mandates from this study." It's Jonathan Ketchum, a public health economist at Arizona State University. And then they quote several other experts that are saying that this study is so flawed that they're even shocked that it's being used by any health district or any health expert to require the mandates of masks. And I just thank you for being here, and I thank all the parents that are speaking out on this issue.
Okay, thank you. And next presenter, please, Russ.
Amber Pearson.
My name is Amber Pearson. I'm an educator, previous principal. I'm a current coach to low-performing schools, and I'm a mother of 3 children in the Boise School District. I'm pleased asking that you consider your recommendations on mask requirements and recommendations on quarantine policies for vaccinated versus unvaccinated to better support the research or lack thereof. At the last board meeting for Boise schools, one of the doctors suggested wearing a mask causes no harm to children. This message has been and continues to be echoed by our school leaders, principals, nurses, coaches, and so on. There is zero consideration to listen to the parents, the doctors, and counselors of opposing views or evidence that suggests otherwise. The above recommendations are leading to extreme mandates with no process to collaborate about the cause and effect. And I can assure you, both in my time in schools as a coach and as a mother, that harm is happening socially, emotionally, physically, and academically. Parents are begging to be heard by the Boise School District, and they're completely dismissed, saying based on the CDC recommendations, there is no harm. I'm going to play a couple videos for you guys. I'm just going to do audio as to not disclose them. This is a child. The parent went to this school, talked about his anxieties, his fears. They were looked at and told no children are afraid to take their masks off. You have to listen carefully.
Wear a mask outside, only in the garden pit. But you're gonna have to be in line, and you don't have separated from people. You're not going to get in trouble. You understand? Is that hard? Let's stay into that's all. We watch you guys, okay?
The little kid there is begging their mom to stay. I'm going to play this next one of a child that does not want to go to school every day. If you could see his face, he has nose sores. A doctor's note has been given to the school. They have refused anything. He cries when he leaves the school.
I always get a watery nose. What does that do? It gets my mouth full and it's annoying. Does it hurt? Yeah. So you want to stay home today because you have a watery nose. It hurts at school to wear your mask. Yeah. Is there any other reasons that you don't want us to go to school? No, just a mask. Okay. Do you wish you could not wear a mask so you could play with your friends? Yes. All right.
I have a couple more of these that I would love to play. These are real concerns and real problems. These children are devastated. They're struggling immensely. When we go to talk to our leaders about this, it is a very hard. There is no harm. My child himself had a bloody nose at school, the white mask covered in blood when he came home. They never changed it. They never talked to him about it. When I brought it up, their response was, why didn't he just go to the nurse to get help? As if these little children should be accountable to that. They say that the CDC recommendations suggest otherwise, and it's imperative that you start listening to parents and counselors and people that are recommending that there's major harm. I could share 100 stories of this. We just don't have time. I thank you for your time.
Thank you.
Okay, thank you so much for your comments. Next presenter, Russ.
Ms. Pearson was the last presenter that signed up.
Okay.
There's others that, let me check to see if there's others that came in to speak, if you wanted to offer some time. Okay, that's it. So we
okay, Russ, what I would like to do, if there's no other speakers signed up, I would like to call for a 15-minute break at this time, so we will reconvene at 10:15.
Okay, thank you. Thank you, Madam Chair. All right, Betty Ann, we're ready whenever Dustin's ready.
Okay,
should be
I am
ready now.
also. Okay, thank you, Dustin. Okay, proceeding with our agenda under new business, we'll have Russ, our director, address the staffing changes. Russ, go ahead.
Thank you, Madam Chair. And we have 3 changes I wanted to share with you on our leadership and management team. That's 2 new hires and 1 retirement. So I'm going to start with our retirement, and he's on with us, Rob Howarth. He's our division administrator for our community and environmental health section. Rob is a frequent guest at our board meetings, so I'm sure you all know him. I want to give just a quick background. Rob started with the state on September 26, 1988 as a part-time hydrogeology intern while I was attending graduate school at Boise State University. In 1989, he accepted a position with the Department of Environmental Quality as a senior groundwater quality analyst, and in 1990, he promoted to an environmental hydrogeologist. Throughout the mid-1990s, Rob also taught geophysics as an adjunct faculty member with BSU. On July 21st, 2002, Rob, I think, made a wise career choice and transferred to Central District Health as a public health program manager too. And then on April 10th, 2005, Rob was promoted to a public health program manager 3. And then in 2016, in June, he was promoted into his current position as a public health division administrator over community and environmental health, which is one of our 3 divisions within CDH. Throughout Rob's career, he accumulated 68,275 hours of service to Idaho. When Rob applied to work at CDH, his resume stated that he is motivated by a desire to learn and to excel in a management career, and that he has an excellent work ethic requiring minimal oversight and supervision. It's clear that Rob is very self-aware of his own strengths when he applied to join our team, and he has proved himself to CDH over the next 19 plus years. I will say that Rob has been a tremendous leadership partner to me and was a key driver behind many of our successes during his time with us. Rob, you have served our communities very well, and you will certainly be missed. And I sincerely wish you all the best in retirement. And I'll give you an opportunity to say a few words if you would like.
Wow, Russ, thanks so much for the kind words. My resume must have done the trick back in 2002. Yeah, it seems like a good chance maybe to thank some people. First of all, I guess I'd like to really just convey my sincere appreciation to the board. You guys are just an integral part of this team of CDH. It's quite a commitment that you take to be a board member, and I know it requires a lot of time, and you suffer through a lot of the same pains that we do and reap the same rewards. So I want to thank you all. Megan, Elt, Betty Ann, Jane, we've worked a lot of years together. Dr. Cole and Raul, unfortunately, not got to work as much with you, but sure do appreciate your commitment to the board. And just want to say that our staff also are really influenced by what you say and do, and really care about what you do. And your continued support of them is critically important, especially, well, when they come and present, and as we try to maintain salaries and provide annual cost of living adjustments. All that is critically important to maintaining our staff. And also sincere thanks to Russ. We have worked well together, I think, in the 16 years that we've been together, and just want to point out what a unique talent Russ is to the organization, and having that 16 years of continuity in the leadership position with someone with the traits and talents of Russ has been just an incredible positive force for the district. He's driven to succeed, and he is always seeking to find better ways to improve health in our communities. He pushes the leadership team a lot. I told him yesterday he's way more of a risk taker than I am, and it's been a good balance. He's kept us moving forward. And I would just encourage you all to take a look at the annual CDH climate survey just to see what staff think of Russ and how they approve of his leadership. He's got a real unique way of getting to know people in a very sincere way. He can tell a lot about most of the staff's family and what their interests are, and it's just a great leadership trait that has benefited us greatly. I'm also really excited about the new leadership team, really, with Laurel, Gina, and then my replacement will be Jamie Annenson, who you might remember worked here for 7 years before spending the last 2 or so years at Southwest District Health. So she'll be coming back to replace me, making such a strong, solid leadership team. And just want to shout out to the program managers in my division, Natalie, Natasha, Lindsay, Laura, and Mike. You've met those folks over the years, and just super excited to have them still here and doing a great job. So it's been my privilege to be at CDH, a great honor. This is where the rubber meets the road and we get things done. And super proud of my time here, and I hope the board is proud of your association with us as well. So I could go on, but just sincerely appreciate my time here and all of the support from all of you.
Well, thank
Betty
you so
Ann?
much, Rob. This is Betty Ann, and I just want to appreciate, on behalf of the board, what you have done. And personally, I have great respect for you and your family. I've been associated with your wife's family for some time. And so just wishing you much joy and success in your retirement, and thanks again. Somebody else was about to speak. Go ahead.
Betty Ann, this is Megan.
Yeah, Megan, go ahead.
I just want to say I'm a little bit glad that I'm remote right now because I am really going to miss Rob. He's been great to work with. I am proud to have worked with him. He's been a great member of the team, and I am sure that he will be sorely missed by more than just me. So thanks, Rob.
Oh, thank you, Megan. And I guess in a way now you work for me since I'm your constituent over in Hawaii County, right? So
Well, you should
keep
probably
that
check those
relationship
maps.
Thank you, Megan.
Madam Chair, Dr. Cole.
Yes. Yes,
I
Dr.
want
Cole.
thank you, Madam Chair. Rob, I want to thank you as well. I know we briefly got to meet during orientation for me, and I just want to compliment you on your service to our community and what a wonderful human you are. And remember to, you never retire, you only rewire. So I hope as you rewire and focus your energies, you find joy in all you do. So thank you for serving so much. And it's so nice to have been able to interact, even though it was briefly. So thank you so much.
Thank you, Dr. Cole. Appreciate the words.
Madam Chair, this is El.
Yes, El, go ahead.
Yeah, I'm going to follow kind of Ryan's comments. Rob, I hope you'll stay active in some leadership stuff. You're too smart of a guy to go home and just crash and burn, so we hope that you'll stay with us. I think the first time I met you was at a mental health board meeting about 7 or 8 years ago, but that's too far back for me to remember, but it's been a real honor and privilege to know you. You're a good person, and you're so easy to talk to and very, very mellow about your approach to things, which I think we need more of in leadership roles these days. And thank you very much for your service.
Much appreciated, El. I appreciated getting to know you, and you're always open and kind, and I've just appreciated that about you. Thanks so much.
Madam Chair, this is Jane.
Yes, Jane, go ahead.
Rob, I can't believe you're leaving. I remember when you came, and I so appreciate all the work that you've done over the years and the way that you offer a perspective that comes quietly from the corner and sort of ties it all together for all of us. We're going to miss you.
Thank you, Jane.
So good luck.
Likewise, I enjoy the rare opportunity I see you out at a ballpark in Meridian or something, so I'll make sure to watch out for you.
Thank you.
Okay, Rob. Well, I don't hear any other people speaking up, so have a wonderful trip with your family. You told me that you're going on a group experience, so enjoy, and we hope to hear from you in the future. So much success and joy to you in your retirement.
Thank you, Betty Ann. Appreciate it.
Okay, proceeding on with number 2 under our new business, we'll have a financial report by Laurel McMahon. Laurel, go ahead.
Betty Ann, it's Russ.
Yes, Russ.
I'm sorry, I have 2 more quick introductions I wanted to do to our management
Oh, I'm
team.
sorry, I cut you off. I was so taken up with Rob's laurels that I...
Understood.
Go ahead.
Okay. So on video, we have Hayden Faulkner, and he'll, oh, there we go. Hayden is a Boise native, which with a bachelor's in psychology from the University of Idaho. He also completed their pre-med dental science curriculum, which served CDH very well when he joined our COVID response team in 2020 to help manage outbreaks in healthcare settings in particular and supervise our COVID monitoring team. Hayden was promoted to program manager with Family and Clinic Services Division, and now oversees several programs, including oral health and First Teeth Matter, infant and early childhood mental health, and parents as teachers. And the latter 2 programs are based on home visiting models to help ensure the children of our community's most underserved families are healthy, safe, and ready to learn. So welcome to the team, Hayden.
I appreciate that, Russ. Thank you. I have an amazing team to ensure the success of the programs, and I'm very happy to be here.
Great. Thank you so much. And the second person I wanted to introduce to you is Zach Ward. Hello, Zach. Zach has worked with CDH since November of 2016, and he was working in our emergency preparedness program as healthcare liaison, which you can imagine required a tremendous amount of effort, starting with the vaccine rollout. That's when things really ramped up, and then also with the training and exercise efforts that were no longer training and exercise, but being put into action. He has a longstanding relationship with our healthcare community, as noted, and has helped them navigate the complex problems of finding, securing, and connecting resources. He has a Bachelor of Science in Health Sciences with a public health focus from Boise State. And Zach brings a collaborative, growth-oriented approach in his leadership style and has a strong change management and facilitation skills to help us continue to integrate and expand our clinic services across our 4 counties. So welcome to the team, Zach.
Thank you, Russ, and thank you to the board for the time for the introduction. And I'm just so happy to be here and really encouraged for the great team that we have. So thank you.
Yeah, thank you.
Okay.
I'm certain that you'll have
Thank
an
you so much.
opportunity to meet both Hayden and Zach in the near future at meetings probably next, I guess we're in winter, but winter and spring, and hopefully we'll be spending more time in the room together.
Okay, thank you, folks. All right, Laurel, now it's your turn.
Good morning to everyone, and thank you very much, and excited too about our new program managers, and very sad to see Rob go. Although we've only had a year of overlap, I've learned a lot from him in that short period of time, and he set such a great example as a leader that I hope I can fill a fraction of the shoes that he's leaving, or help to be a part of the team that does at least. Moving on to our budget report, Dustin is pulling up the screen here, and I know you've had a chance to look at it. As you've looked at it, I hope you've seen that we're seeing pretty similar things to what we typically do at this point of the year. We're 5 months into the year. This goes through the end of November, so just under 42% of the year has elapsed so far. And as you can see, our total revenues are looking good at 45%, so slightly above where we'd expect to be at this point of the year, and our total expenditures are at 38%. Or slightly under where we plan to be at this time of the year, but both of those things are pretty well on track. To look at a little bit more detail on this page, you can see our total fees revenues in that top left quadrant are above budget at 47%. And again, that's what we normally see this time of year with our food fees coming in November. You see that in the community environmental health line, and those are due before January. So we always see that uptick between the November and December months. FCS, you can see there is at 35% of budget for fees right now, so slightly under where we plan to be, but we expect to continue to see those to raise over the next couple of months and into springtime. Our total contracts are above where we plan to be at this time of year, and that's because we continue to receive additional contract and grant funding. So any grants that we didn't know we were getting when we put the budget together last spring timeframe, spring and early summer, show up in that contract revenues area. So when that stuff comes in, it makes us a little over budget. And then when we do the budget revision and can account for those things, we get back to where we plan to be. Our other revenues are high. And as a reminder, those are because of the way we receive some of the funding streams in those categories, including Millennium Funds, which say CRP. The support services revenue that you see there is based on the auction of surplus property. And then the FCS revenue that you see there is from state home visitation. So brings us again to overall where we'd like to be at this time of year, about 45% of what we had planned to for our revenues. Looking at expenditures really quickly, again, we're really close to where we plan to be. Our total personnel is slightly under budget. We have had some position vacancies and some salary savings through retirements and people who have been with us for a long time moving on. So a little bit under where we plan to be there. And then our operating budget is right where we want to be at about 43%. So things are looking good there. You can see our capital outlay is at 23%. And as usual, we have that funding set aside. We still have some remodel funding set aside, which we're planning again to finish that up in January of this year is when we'd like to start that final phase. So coming up very quickly, but that does depend. Our big dependency there is when we have the facility space to complete that. And that is dependent on the COVID staff and our response efforts and how much space we need in the building to accommodate those extra staff. Moving on to page 2 of the report. And this is just that different way to look at it. This gives us that year-over-year comparison. As you can see, when you look at our fees here, we're right about where we were last year. And between last year and this year, we're way above where we were a couple years ago. And we expect to continue to see that growth in both CEH and family and clinic services. Contract fees continue to grow. We expect to see that really significant growth there over the past year-over-year comparison. And then with our opioid funding and additional funding sources that we know we'll be getting soon, by next year, we'll see an even bigger growth there. So our summary on this page of revenue shows that we're 12% over for our fees, 26% over for contracts. And then summary for expenditures shows that we're about 12% under for our personnel costs overall and right about where we expect to be again for those operating costs. And then finally, we can move on to the cash balance statement. And this is the one I like to look at the best or the most because we can show you where those projects that we set aside reserve funds for, we can finally start to see some of the progress on those projects. So that's a good thing. We did end the month with a total cash balance of about $6.5 million. When you take out those reserve fund designations, that leaves us at that bottom number there, that $820,000. That's about $200,000 above where we often are at this time of year. And that just has to do with the way we've planned for spending and funding with some of those projects. And I would like to highlight some of those. So where I'm looking on the page right now is in that special projects carryover designation. So the first number you can see, last time I did this report, those were all still zeros. We hadn't had any funding come through on those projects yet. So this time for the IT operating budget, that $35,000 that you see there, that's been for our Office 365 implementation, which is on track and going well, and allowing us access to a lot more tools to do our jobs more efficiently and effectively. So we're excited about that. We have had some facility maintenance and service projects and facility modernizations that you can see that show up on this page as well. And I do want to draw attention to that facility modernizations, that $48,000 there. That's mostly from our Mountain Home remodel. And the good update on that is that the construction for the remodel of our mountain home building, which as a reminder was funded by Health and Welfare so that they can effectively co-locate in that building with us. The construction there is complete. The inspection for that was scheduled for this week. The only thing that we have left to do, which was an add-on, is finish some carpet replacement that we'd planned there. And that should be done by the end of the calendar year. So as of the end of this month, so in just a couple weeks, we will happily have Health and Welfare, Department of Labor, and CDH co-locating from our CDH building in Mountain Home and just offering that really wide range of services to the Mountain Home community. So really excited to see that special project come through there and be at that point of completion. You'll also notice on here we have our CDH grant writer that we set aside some funding for. We were successful in hiring a grant writer, but unfortunately she was only with us for about a month and a half and was offered another position. So we are actively recruiting again for that grant writer and looking forward to bringing that person on to the team and hopefully longer term so that they can continue to help us with that grant and contract funding and expanding the business that we have and interact within the community. Okay, and that is all for the cash balance statement. I'll stand for any questions that you might have.
Madam Chair, Zell.
Betty Ann?
Yes, El, go ahead.
Laurel, the 75,000 you have for the grant writer, is that going to be enough? My concern is you've already lost one. Is it a salary issue or was it something else?
You know, El, it was an issue. The place that she had worked for before offered her a promotion and a raise to come back to.
Okay.
It was just a really lucrative opportunity. She did great work for the time she was here. She put forth a couple of grant opportunities that I think we'll still end up pursuing. I think it's just a reflection of where we're at economically and that it's really a job seekers market, and she got a better offer. We do think the salary that we're offering there is competitive. And we're hoping to be able to recruit really well for that position again.
I guess my only statement is if that is not enough, would you please come back to us and maybe request more? Because I think that position is going to be a little costlier down the road, but they pay for themselves pretty quickly. So thank you.
So noted. Thank you.
Betty Ann?
Yeah, yes, go ahead, Megan.
Thank you. Hey, Russ, before January 10th, could you please do a quick primer with me on the home visitation stuff with the state?
Madam Chair?
Yes, go ahead, Russ.
Yeah, that would be great. I would appreciate that opportunity.
Okay, thank you.
Madam Chair, this is Eld again. I'm sorry.
No, go ahead, El.
Laurel, I'm really glad you guys put in some room at the Mountain Home office for Department of Labor. We're having the same issues in Valley County and they're looking for a home right now. Unfortunately, we have a real challenge with our county facilities for room. So it may pay to consider expanding some of that office in McCall for Department of Labor as well. I know you have, 50,000 for some of those improvements, but I think we need to keep that back in the back of our minds because if the economy tanks, those people are lined up. So just so you know.
Madam Chair?
Yes, go ahead.
Yes, we are in talks with Department of Labor in Valley County right now, and they have expressed that very sentiment that the location they're at is not ideal for the services they provide. And so they will be doing a walkthrough of the facility there to look at what space might be ideal for them and if we need to make any modifications sometime in the next couple months.
Thank you very much. Appreciate that.
Okay, any further questions or discussions from Laurel on the financial report? If hearing none, we'll go ahead with the strategic plan presentation by Laurel. Laurel, go ahead.
Thank you. And I will wait for Dustin to pull up the slides on this. I'm really excited to be able to do this presentation on the strategic plan for you today. I've had it in the hopper for a couple of months and have made a few adjustments to it to make sure that it's all updated, but really excited to be able to share our progress. So moving on to the first slide, just letting you know what we're going to cover, and this is a pretty brief presentation. But since we haven't talked about the strategic plan in a while, we're going to talk about what's in it and where we're at. I'll give you a refresher on what the board scorecard looks like. I'll tell you in advance, the graphic for it's a little bit small, but we will take it in chunks that I hope are visible and you can see them and clearly see where we're at. And then I want to talk a little bit about the planning phase, or what's coming next for our strategic plan, and what you can expect to see in terms of frequency of updates and what should be in it. So we'll move on to the next slide, and I'll show you a graphic that you have seen before. This is our strategic plan for 2020 to 2023. This is located on our website if you want to go out and check it out and look at it in more detail. We always keep the strategic plan there and updated. And as a reminder, we've got 3 big priorities areas here. And since the writing is a little bit small, I will read what they are. Efficient, integrated, and quality services is our one main priority area. Our second one is a skilled and engaged workforce. And then the third one is a reliable community partner and health advocate. And those things really all tie together. We want to be able to provide good services, have a workforce that is good at providing those services, and then continue to grow and strengthen our programs to really impact the health of the community, which ties into our overall vision of healthy people in healthy communities. So our strategic plan sets us up to do the work to do that. And then below the priority areas, we've got those goals. I will not go into all of those. And below the goals, we've got our objectives and strategies. And the scorecard, which we'll look at next, shows you this level, the priority areas, the goals, and then one level below that. So if we can move to the next slide, this is the graphic that I warned you about was really small. You don't have to squint to see it. I am going to break it down on the next slide so you can see it a little bit more clearly. But here's where we have it broken down with our indicators of how we're doing. So anything that you see is green, it's on targets where we expect to be. We're doing well, making progress at those things. Anything you see with a yellow exclamation point needs attention. So these are areas where we are making progress, but we really want to continue to pay attention to and make sure that we're doing that intentional ongoing effort to continue to expand and grow those objectives. We don't have any red X's on the screen, but if you saw those would mean we're completely off track. Something's gone way wrong with that objective, and for some reason we're not able to meet what we were intending to do there. And then the other thing that you might see up there, but we don't have on the report card today, is a strategy not active. So if we've changed our mind about a priority or something, we've maybe rolled it forward to another operating period, you might see a gray asterisk up there letting you know that we're not working on this right now. The good news on the strategic plan is that we're all either on target or actively working towards things, but needing a little bit more attention to get them to the levels that we want to be. So great news on the board scorecard. And we can move on to the next slide, which is that breakdown of that first priority area. So this is the efficient, integrated, and quality services. And you'll see a range of goals here, several of them in the clinic, a couple in support services, and then one in community and environmental health as well. I will not read through all of these. If you have any questions about the things that I don't go over in detail, I'm happy to answer those or get answers to you. But I do want to draw your attention to just the 3 where you see the yellow exclamation points. So those 3 are expanding telehealth to all counties, increasing WIC participation through recruitment and retention efforts. And then the last one where we want to continue to pay that attention to is to increase participation in FCF services and potential revenue. So again, those are areas where we're on track. We're doing a lot of work to get us towards those goals, but we really want to keep focusing because we're not quite where we want to be yet. And if you can go to the next slide, I can go over some of the highlights for this priority area. So the things I wanted to share the most about the work that we've done from this part of the strategic plan is that pediatric services are now offered in all 3 of our CDH locations, and our primary care services have expanded as well. I lost visual on the board. Okay, it's back. Hopefully you didn't lose it on me or lose volume. I'll keep going and assume that you can still hear me. The next thing is that our telehealth infrastructure is in place. And this is one of the areas where you saw that yellow exclamation point, and that's because we want to continue to expand our use of telehealth. We're set up and ready to go, but we're not using it as broadly as we think we could, especially to provide some healthcare services in our rural areas. So we'd like to continue to work on that. Another area where you saw that yellow exclamation point is our WIC participation. And what I can say about that is our WIC participation has increased, but we know it's not where we want it to be. So continued growth is going to be a continued primary goal there, and we'll keep working towards that. And hopefully our marketing plan will help us impact some of that growth, and we'll talk more about that on coming slides as well. Last thing I'd like to point out here is that our use of electronic formats has increased greatly. And that goal was associated with the Community Environmental Health Division, but we have increased our use of electronic formats across all 3 of our divisions. So we've done that in family and clinic services with some better online patient intake forms. We've done it in community environmental health through electronic childcare inspections, and we've done it in support services internally with automating a lot of our processes that used to be paper. So really working across the agency to increase that use of electronic formats. And we can move to the next slide. All right, this is that priority area B, the skilled and engaged workforce. And good news here, all green check marks to go on. Won't go into too much detail on this page. I know the font is small, and the next slide will show us our highlights here. If we can move to that, please. So these are some of the things we've done in this skilled and engaged workforce area. Our workforce development opportunities, we've really looked closely at those as an agency to say, you know, what can we do to maintain our staff, just increase that retention, do better at recruitment. So a few of the things that we've done are to begin quarterly supervisory training sessions. We've also expanded how we support our job-related education, hoping that that's a retention benefit as well. Our CDH branding effort has been in the strategic plan for a while. That's been successful, and we're going to incorporate it into our marketing plan too, to increase our use of the branding that's happened internally. The other thing I want to point out in this section is that we know, based on where we're at economically everywhere in the state and the country, is that employee recruitment is a challenge. We acknowledge that. And we do have a higher turnover rate than we would typically have. Some of that is our COVID temporary staff who tend to have higher turnover than the rest of the agency anyway. But the good news, the highlight here, is that we do continue to find good candidates when we do have open positions. Sometimes the candidate list is significantly smaller than what it would have been before, where we would have had double digits, 20 or 30 applicants. Sometimes we're down to 7 or 8. So some significant changes in the number of people applying for our positions, but we are finding quality candidates across the board. Right, and the last area, and this looks small on the screen, but this is where we spend a lot of time and attention. This is that reliable community partner and health advocate. And we've got goals across the board here too in FCS, CEH, and administration. And we continue to make good progress here. This is where we want to see that partnership, that getting the word out in the community, growing our programs, improving the number of services and how broad the services that we offer are. This is where those objectives and strategies fall under. And we can go ahead and move to the next slide here for some highlights. Right, and one of the big accomplishments here has been establishing a community health worker position. That took a little while to set up. I think the board's been updated on that a couple of times. So that community health worker is actively working to help our clients navigate and figure out how to tie resources together, increase their self-sufficiency. How do they overcome language barriers? How do they bring us the documentation that we need? All of those types of things. We've got a community health worker in place to help smooth out some of those barriers and improve the services that we're offering there. WHC continues to work on their goals, transforming the social determinants of health. That's something I know you get updated on somewhat regularly as well. And then the final thing that I know we've talked about a couple times here is that our marketing consultant has almost completed their marketing plan. And as soon as we have that marketing plan complete and approved, we'll work on materials development and implementation of that plan. And again, tying it back to all the other things that we mentioned to improve our growth and the services that we offer and getting the word out about them. Okay. So we can move on to what's next. Right now, in this month, I'm starting to begin to gather information that we want to include in the next strategic plan. So the next strategic plan is going to cover the time period of 2023 to 2026. I'd like to have a draft plan together in March or April of 2022. And then in July of 22, when FY23 starts, we'll have that new strategic plan ready for implementation and ready to go. Some of the things that I would like to focus on for the new strategic plan is making it a little bit more clear what success looks like. So as you look back through the scorecard and look at some of our strategies and objectives, you'll see that we have language like improve, that are a little bit broader than I would like to see in a strategic plan. So as we move forward for the new strategic plan, we'll work on visibility for what success looks like. How are we meeting those metrics? How do we tie them into our dashboards and the measures that we're looking at on a regular basis and have everything tied in together? I mentioned at the beginning that our primary focus area is tied directly to our vision. And we want that to flow all the way down so that the metrics we're seeing, what we're looking at every day and what we measure go all the way back up to that vision, and then that vision is imbued in the things that we're measuring. So really trying to operationalize it, make sure that we know and you know what our successes look like, and then the plan will represent that and have the detail level that we can report back to you. So that is the summary where we're at with the strategic plan. Really excited about all the work that's been done. And just as a reminder, as I go through all of those highlights, that's all work that we've been able to do while we're focusing on our pandemic response efforts as well. So it's always refreshing for me to highlight the fact that we've kept all of this other work going. We did have to adjust some timelines here or there due to our focus on the pandemic response, but overall, we've kept all of these strategies moving forward and at a point where we can report back to you on the good work that's been done. So that is all I have, and I will open it up, Madam Chair, to any questions or comments.
Okay, thank you, Laurel. The floor is open for questions.
Madam Chair, this is El.
Yes, El, go ahead.
I'm not sure whether to bring this up or not, but maybe Laurel, something to think about for the new strategic plan is, I think, you know, a lot of it's because I don't know really what's going on, but we've got to start to figure out a process for Boise County. Boise County's kind of been the stepchild of this group for quite a while, and I think there's maybe a little bit of lack of leadership on those local folks. I know there's a big argument about the county seats in Idaho City, but the biggest populations are in Garden Valley and Horseshoe Bend. But I don't know if we're doing any kind of dental for the schools. I don't know what processes, but I think we need to start kind of thinking about a plan to get some of this stuff done in Boise County. What's your feeling on that?
Madam Chair?
Yes, go ahead.
Yeah, thank you, Commissioner Hasbrook. I know that we have expanded some of our services very recently to Boise County, and Russ may be able to give you a little bit more detail on that. But I think it's a great idea to maybe include some county level goals in the strategic plan. And as we're looking at program expansion, so right now we might have, a goal to expand participation in a program by 5%. But we could even look at doing that by county level. Maybe in Boise County, we want to grow a program by 10% by a certain time frame. So as we start to put those metrics together, I think that's a great idea to include some county level goals.
Well, and Madam Chair, I think too, there's a really good opportunity for the telehealth in Boise County. They're kind of like Valley County. They're really short on broadband, so that's the big issue that we're dealing with right now. But we've got to lift them up, I guess is what I'm trying to say, and hopefully get them more services. So for a strategic plan, I think that should be one of the considerations.
Thank you.
Madam Chair.
Yes, Megan, go ahead.
Yeah, I'm struggling because I know that we at one point in time had metrics and we were targeting to make sure that each county got somewhat comparable services, and we were trying to equalize to some degree. And where was that report? I guess I'm having a hard time remembering where that was, if anybody remembers.
Madam Chair, Russ.
Yes, Russ, go ahead.
A couple of years ago, those were tied to my goals, actually, as the director. And I would share with you, as far as the work that we do in Boise County, that we offer many of our services there. Obviously, we have a full-time dedicated environmental health specialist, Jerry Davis, who does an outstanding job. We provide WIC services, we provide dental services, we provide immunization services. We also offer home visiting services, and we're really working honestly very hard to get that going because I don't think it come to surprise to anybody that it's a high need community in that regard, but just trying to make inroads with natural community leaders. And of course, we've developed a strong partnership with all 3 school districts in Boise County with the COVID response. So I want to make you aware, I mean, we are focusing a lot of effort on Boise County. We do our county data sheets, which I'll be sharing those with you later this spring, that we take to the county commissioners during their budget requests. So yeah, there's a fair amount of work and more work to be done. I think to your point, Commissioner Hasbrook, with the opioid funding that we're going to get, at least $400,000 a year, Boise County will certainly be an area of emphasis, as well as throughout our health district.
Madam Chair, this is Elt again.
Yes, Elt, go ahead.
Just for information, we've been notified by YCAP, which is kind of a federal program in our county, that they're going to a more mobile kind of an application, and they're not going to need facilities. And I know there is a YCAP facility in Horseshoe Bend. I don't know about Garden Valley, but there may be an opportunity there working with those commissioners to maybe use that facility if it becomes vacant. Just things like that, the little things like that can make a big difference as far as our goals and what we'd like to try and do. So there's some changes coming on the low-income service right now for a lot of these counties that it's going to be different for folks. And there's an opportunity we may be able to use some of those facilities for other things, which is kind of what we're looking at in Valley County right now. Our YCAP closes the end of this month. Just so everybody knows. Thanks, Laurel. Great job.
Madam Chair, this is Jane. I had one question.
Yes, Jane, go ahead.
Laurel, I love the way that you're talking about the transparency of what they're doing each day, going into the daily, weekly, monthly, yearly goal. That's going to be awesome to watch as it goes by. And I wanted to know what you're seeing as the telehealth in the future. Like how does that fit? What services are you talking about?
Madam Chair?
Yes, go ahead, Laurel.
So this is a question I think that Gina's expertise would be better to answer. I'm not sure if she's prepared to do that now or if we should get back to you on it. But if Gina is available and can answer that, I'll turn it over to her briefly. Looks like a yes.
Hi, Madam Chair. Could you clarify your question again for me?
This is Jane. I just wanted to know what types of services are going to be offered and how you see using the telehealth and where.
Yes, absolutely. Thank you for the question. So a couple opportunities that we have for our primary care services and our reproductive health services that can be offered prior to a visit. So some of the opportunities that arise are when someone just needs a quick consultation. We notice that we have a lot of individuals who call our clinic who just want to talk to a provider, and as a medical practitioner, it's really challenging to accommodate those particular requests, knowing that sometimes a medical exam is required and other times it is that consultation. And so we would want to emphasize, through our marketing plan on our website, as well as through our front office staff, kind of what services are available for those individuals to be able to receive via telehealth, where something could be started, a prescription could be given, where you don't necessarily need that initial exam, and then you can move forward with a follow-up for the exam to make sure that everything's going okay and that check-in with the provider. So there is a little bit broader scope, and the new telehealth rules do allow for that. That was a positive sort of silver lining from COVID. And so we're working with our teams to help amplify that through our marketing plan, which is hopefully going to roll out here in January.
Thank you.
Thanks, Laurel.
Hey, any further questions or discussion points for Laurel? Well, Laurel, I want to thank you for that amazing report and look forward to the future. So thanks again. And we'll move on with Lindsay Haskell's report now on our review of our COVID-19 status. Lindsay, go ahead.
Good morning. Thank you, Madam Chair and Board. A lot of what I have mirrors what Dr. Hahn presented today. It's our local district level data that does closely mirror state level data. Next slide. So this is our total cases and total deaths. You'll see we're at 94,000, just over 94,000 total cases of COVID-19. We anticipate we will reach over 100,000 cases in early 2022 and over 1,000 deaths. Next slide. This is the percent positivity data for our health districts, all counties. We saw a peak back in September, dropped down, and starting to see a plateau just above 5%. We're hoping to see that go down just a bit more under the goal of 5%. Next slide. This is the overall cases by week of report and the breakdown by age group. By week of report, you'll see we peaked back in September, have had a steady decline, but now seeing a bit of a plateau in numbers. And you'll also note the age breakdown, still that 19 to 29 is our highest amount of cases, but that 0 to 18 age range continues to grow and will likely be the second highest within the next few weeks. Next slide. Just again, a breakdown of Ada County by week of report. Saw the surge and the plateau. Next slide. Boise County was really hit hard by this last surge with the Delta variant. You'll see higher case numbers per week and for a longer period of time, and now that plateau. Next slide. Elmore County also saw in this last surge much higher numbers than previously recorded and is continuing to see that decrease potentially into a plateau. Next slide. Valley County has not seen quite as steep of a decrease or a plateau yet. It is lower numbers, so we'll see those graphs change or look more dramatic with just a difference of 1 or 2 cases, hoping to continue to see decline or more of a plateau with Valley County cases. Next slide. Hospitalization data. So this data is specific to our health district residents in our local hospitals. You'll see that the peak was in end of September, beginning of October, slow declines, and now a slight increase again for ICU hospitalizations, and a decrease and then plateau for just hospitalizations. Next slide. This slide is not necessarily District 4 residents, but reports from District 4 hospitals. So again, seeing those steep decreases in the amount of hospitalizations and people requiring care in the ICU, seeing much slower declines and a slight incline in hospitalizations. The bottom graph represents the number of ICU beds available, and you'll see that we are still having lower availability of ICU beds than we've seen previously this year outside of the surge, but those numbers have increased slightly. Next slide. Vaccine breakthrough info was last reported to us a month ago from Health and Welfare. We had 8,166 vaccine breakthrough cases in our district, with 134 hospitalizations and 60 deaths among those vaccine breakthrough cases. Those proportions mirror very closely to what Dr. Hahn presented. It was about 15% of our cases this year. Over 30,000 of our cases occurred during this last surge, so more than half of the total year. So after most groups were eligible to be vaccinated outside of that 5 to 11 age group. Next slide. Overall, our indicators all peaked, but continue to be high. We're seeing declines slower than we've seen in the last few weeks, now starting to plateau. All of our counties continue to be in high transmission, so risk of being exposed to COVID is high when you're out in public. And we're watching closely to see if these indicators start to decline further, stay plateaued, or increase, especially with the Omicron variant. Next slide. Information can be found on our website, Health and Welfare's website, and CDC's COVID tracker. And that's all. I will take any questions, Madam Chair, if that's okay.
Yes, the floor is open for questions for Lindsay.
Madam Chair, this is El.
Yes, El, go ahead.
Lindsay, just so you can keep in the back of your mind when the data starts rolling in, that in Valley County, we had 3 weeks of road closure. And I'm really interested to see what that did to our infectious rate. Just to see if there's even a drop or a dip. It was the #1 complaint to me for 3 weeks straight, but I was interested just to kind of see what that's going to do to the coronavirus and the issues we have up there. Maybe all we need to do is close all the roads for 3 weeks and our problem would go away.
That would be great for your economy.
Right.
That is a great point. We'll keep that in mind when looking at Valley County data.
Thank you.
Anything else for Lindsay? Well, hearing none, thank you, Lindsay, for that report, and hopefully our numbers continue to trend downward. So thank you so much.
Thank you.
Okay, proceeding on, we will review our COVID-19 vaccine status and share information on the monoclonal antibodies and antiviral medications by Natalie Bodine. Natalie, go ahead.
Thank you, Madam Chair, and good morning to the board. We'll just provide a handful of slides and a quick update on our vaccine planning and distribution efforts. Next slide, please. So looking at some updates that have happened since we last met in October, I believe. So on October 15th, the FDA's advisory committee did approve emergency use authorization of the Janssen COVID-19 vaccine for a booster dose for all individuals 18 years of age and older. And then on November 19th, the FDA approved the COVID-19 booster doses of Pfizer and Moderna for all individuals 18 years of age and older. And then at the end of November, on November 30th, the FDA's Antimicrobial Drugs Advisory Committee recommended authorization of Merck's COVID-19 antiviral pill. And this is a pill that is for those with a recent diagnosis of COVID-19 and works to lessen the effects of illness from COVID-19. Again, hoping for this medication to be free to anyone who needs it, and it would consist of a course of pills taken over a number of days. This has not yet been approved, but if approved, it will be available in limited quantities through our pharmacies, and the state is working with Albertsons and Walmart in Idaho to provide that pill once approved. Next slide, please. So again, presenting some information on our vaccination data and rates across our jurisdiction and per our counties. I wanted to pull up this slide as I'm going to be presenting our vaccine data just a little bit differently than I have at previous Board of Health meetings. As Idaho Department of Health and Welfare, who manages this site, has recently updated the COVID-19 vaccine data dashboard to include the 5 to 11 year age group. So we have some more data points here. And if you look on this slide on the top left, you can see that you can select a different geography. You can look at county rates, or you can look at rates across a particular public health district. And then there's 4 different rates that they're now identifying and looking at, providing data on. That's the rate of population for ages 5+ that are fully vaccinated, rate of population of age 5+ with at least 1 dose of a 2-dose series, so their series is in progress, and then rate of fully vaccinated population with a booster dose. And when they say booster dose, does not delineate those that were immunocompromised that may have gotten a 3rd dose to complete their series, or those that have received an actual booster dose. So it includes both of those in that booster dose definition. And then the final data point that they're looking at is the rate of population age 5 to 11 with at least 1 pediatric dose. So I would recommend going out to their site. Dr. Hahn did reference that on the coronavirus.idaho.gov website. A lot of good information that's being provided on their COVID-19 vaccine data dashboard. And all the data that I will share today was recently updated on Wednesday, which was December 15th. Next slide, please. So taking a look at these 4 vaccination rates for Central District Health. So this is a combination of our jurisdiction and the 4 counties. Rate of population for age 5+ that are fully vaccinated, we are sitting at 60%. Rate of population for our district age 5+ with at least 1 dose in a 2-dose series is at 5%. Rate of fully vaccinated with a booster dose is at 40%. And rate of population age 5 to 11 for our jurisdiction with at least 1 pediatric dose is at 23%. And again, the 5 to 11 age grouping became eligible for COVID vaccine end of October, early November, so just about 2 months that they have been eligible. Next slide, please. So the next 4 slides, I did a breakdown for each particular county on these 4 different rates. Again, this slide looks at the vaccination rate for Ada County, that rate of population for the 5+ that are fully vaccinated at 61%, rate of population age 5+ with at least 1 dose of a 2-dose series is at 5%. Rate of fully vaccinated in Ada County with a booster dose is at 41%. And then that rate of population for that age 5 to 11 with at least 1 pediatric dose is sitting at 24%. Next slide for Boise County. Again, these 4 data points, rate of population, age 5+ fully vaccinated is at 30%. Rate of population, age 5+ with at least 1 dose of a 2-dose series is at 3%. Rate of fully vaccinated with a booster dose is at 37%. And rate of population age 5 to 11 with at least 1 pediatric dose in Boise County is at 4%. Next slide, please. Looking at Valley County, rate of population age 5+ that are fully vaccinated is at 58%. Rate of population age 5+ with at least 1 dose of a 2-dose series is at 6%. Rate of fully vaccinated with a booster dose is at 42%, and rate of population age 5 to 11 with at least 1 pediatric dose is at 23%. And last but not least, looking at Elmore County, rate of population age 5+ that are fully vaccinated is at 37%. Rate of population age 5+ with at least 1 dose of a 2-dose series is at 5%. Rate of fully vaccinated with a booster dose is at 26%, and the rate of population for the age 5 to 11 with at least 1 pediatric dose is at 7%. And again, for Elmore County, these rates do not include information from Mountain Home Air Force Base. Did receive an update from them. Thank you to Lindsay for reaching out to them. And they have reported as of earlier this week that 95.7% of military members with Mountain Home Air Force Base that are on installation are fully vaccinated. They do offer vaccines to dependents on base as well as booster doses, but they currently do not have those numbers for those at this time. So wanted to mention that again, that these rates will be higher than what you see on the screen here if we include those Mountain Home Air Force Base numbers. Next
Madam
slide,
Chair.
please.
Yes.
Madam Chair.
Yes, go
Sorry.
ahead, Megan.
I just wonder, since we play this game every time we get this report, can we please put an asterisk on the vaccination or on the dashboard or wherever this data is going to indicate that it is not accurate of the entirety of Elmore County? Because that's great that we get the verbal explanation, but it needs to be reflected on the data that's presented by CDH.
Yes, this is Betty Ann. I agree, because the numbers really are reported are much lower than we actually have. So thank you.
Okay. So this graphic or slide that you're seeing now are vaccines administered by age group, and if you see on that top right, the geography is this is numbers that look at our health district as a whole. So this is covering all 4 of our counties. So wanted to provide this slide that actually breaks down the different age groupings and the different rates for each age grouping. Next slide, please. So wanted to give just a little bit of information on monoclonal antibody treatments. Dr. Hahn did speak briefly about some of the MABs that are offered. So monoclonal antibodies or substitute antibodies are those that are developed in a laboratory to help our bodies fight infection. And they have shown effectiveness in reversing sickness from COVID-19 and reducing the rate of hospitalizations. MABs have been granted emergency use by the FDA. And who qualifies for monoclonal antibody treatment for COVID-19 would include people that are 12 years of age and older who have been diagnosed with and tested positive for COVID-19 within 10 days of symptom onset, and people 12 years of age and older who are at risk of progressing to severe disease or hospitalization due to COVID-19. The treatment is free of charge regardless of insurance status, with no patient out-of-pocket costs, and must be ordered by a licensed provider. A provider referral is required to get the treatment. Monoclonal antibody treatments are currently available through a limited number of providers in the Treasure Valley. And just a few months ago, Governor Little did make about $600,000 available for the development, establishment of a community monoclonal antibody site in the Treasure Valley. And in early November, a community monoclonal antibody treatment center did open in Boise called Direct COVID Care. And DCC can treat up to 100 patients per week, and that includes both pediatric and adult COVID patients 12 years of age and older, across southwest Idaho and surrounding areas. And I do know that within the last few weeks as well, over in District 3, another community monoclonal antibody treatment center in Salter Health opened as well. Next slide, please. So this is data that we receive weekly from Idaho Department of Health and Welfare. This is data that is reported by those facilities to HHS Protect and just shows the weekly administration of monoclonal antibodies in Ada County. Next slide, please. So again, just contact information and some resources and websites. And I do want to add that we are looking at, due to a low volume in calls coming into our call center over the last few weeks, we are planning for the demobilization or the closing of our call center at the end of the year. And of course, we will maintain that capability. If we see another surge or another need from our community, we can quickly open up our call center again. But it has been operating since March of 2020, so it has been a tremendous resource for us. So that will be closing at the end, and we'll look for updates on our webpage as to other resources available. And that is the end of my report. Madam Chair, I'll stand for any questions.
Okay, thank you, Natalie. The floor is open for questions.
Madam Chair, this is Bronwell.
Yes, Raul, go ahead.
So I have a question about the monoclonal antibody treatment. You said that they were available free to the public, but I've heard complaints from several people that they're having to pay $1,000 or more at some of the local hospitals. Can you maybe educate me a little bit better on that, and so I can give the correct information when I'm asked?
Yeah, Madam Chair.
Yes, go ahead.
You know, I do not have, I can't expand on that as far as the hospitals. Russ, or if there are others on the line that may have some more information on the treatment.
Madam Chair, it's Russ.
Yes, Russ, go ahead.
So Raul is correct. The health systems, so basically the drug itself is free, but the health systems charge for the administration of it.
$1,000?
It varies. They bill insurance, they have financial assistance, but the clinic on State Street that's funded through the state that primary care providers can and should be referring their patients to, it is completely free, is my understanding. So if you go through the health systems, you're going to get the medication for free, but the infusion services are at a fee.
Madam Chair, follow up.
Yes, go ahead.
So is this new that we are getting the outside of the health system monoclonal antibody treatment? When did that start? And how do we make it more available to the public so they realize that there is a place where they can get it for free?
Madam Chair?
Yes, go ahead, Russ.
It has been available for more than a month. And what Central District Health did, because I'll just back up, you can't just go to the clinic. No one can go to Al's or Luke's. You have to have a referral from a primary care provider. You have to meet certain qualifications to be eligible for the treatment. So what we did, we sent out what's called a health alert network. We did this actually a number of months ago, notifying all the primary care providers throughout our public health district of here's the criteria, here's how you refer patients. And then once the new clinic came online off State Street, we actually coordinated a call with all of the primary health clinics, all of the providers actually throughout our district and public health district 3, because there's some overlap there. So Seltzer, Primary Health Medical Group, St. Al, St. Luke's, and small providers as well, anybody that we had contact information. So we facilitated a call with them. Dr. Williams, it was actually in the news. He spoke to all the primary care providers as far as what services they have, how to do the referrals, to make it as seamless as possible. So if you're a St. Luke's patient, you're probably very likely to get referred to St. Luke's or St. Al's. But outside of that, if you go through like an urgent care clinic system, then they would have this option to send them to the treatment center on State Street.
So, Madam Chair, just one last follow-up. Sorry, for any media that might be listening to this, people need to understand that St. Luke's and St. Al's and all these hospitals are actually receiving this for free and charging a huge fee, and there's actually a place where they can get it for free, and they should ask their providers to send them to that place.
Madam Chair, this is El.
Yes, El, go ahead.
Natalie, I just had a question on the monoclonal antibody treatments, the last page. Can you tell me kind of off the top of your head, how old are folks that are getting these kind of treatments? Are these elderly folks, or are these folks with stressed immune systems, or kind of go along with what Raul was saying, is there minimums? I mean, how do you get into this kind of a deal?
Yeah, Madam Chair?
Yes, go ahead, Natalie.
Yeah, so I don't have exact data on the different age groupings of those who have received the treatment. I can write that down and see if I can get that information. But as far as who qualifies for the treatment, It's people that are 12 years of age and older who have been diagnosed and recently tested positive and are within that 10 days of symptom onset, and or people that are 12 years of age and older who are at risk of progressing to severe COVID disease or hospitalization. And there are some risk factors that may be included but are not limited to, including those that are 64 years of age or older, obesity, pregnancy, chronic kidney disease, diabetes, chronic lung disease, immunosuppressive disease, and cardiovascular disease are some additional risk factors that may be included.
So, Madam Chair, as a follow-up, then it's not like anybody can just walk in there and say, I want to get a monoclonal infusion. I have to be a special needs kind of a situation with a stressed immune system or obese or pregnant before you're going to qualify. And I'm assuming that's where the breakdown is coming between the hospitals charging a fee and it being free, is that maybe there's some folks that aren't in that category that can't be forwarded to the State Street clinic. I don't know. I'm just assuming, but all of a sudden everybody made a mad dash down the State Street to get that done. I don't think that's going to work very long. I don't know. Do you know, Jane?
They have to be referred.
So it's a
They have to be
referral.
assessed, and then
Yeah.
we refer them. And even at that, there's no guarantee. But on State Street, they're not charging for the active
Treatments.
infusion.
Yeah.
And they're not charging for place of service to administer the vaccine, as far as or the monoclonal antibodies, as far as I understand.
And just to clarify, that they have to be referred even to the hospital, right? That you can't just show up at the hospital, get it. So I think it's the same people who it's just some people are being referred to the hospital and getting charged. Other people are being referred somewhere else and not getting charged. I think that needs to be.
Well, and it's confusing, because if their insurance comes from St. Luke's, then their mentality is to start there. And
I think that's, people just need to ask more questions.
Yeah.
Right.
Thank you, Natalie.
Madam Chair.
Yes, go ahead, Megan.
Yeah, I would just, I don't know if it clarifies or not, but I had a couple that are friends of mine. One of them qualified for, both of them ended up with COVID. One of them qualified and one was immunocompromised and was referred and did go to the hospital. And it's not one of the Treasure Valley hospitals, so I'll check to see, just to follow up to see if they charged for the service or if that was free.
Okay, thank you.
Madam Chair.
Any further questions?
Yes, please, Madam Chair. Dr. Cole.
Yes, Dr. Cole, go ahead.
Thank you, Madam Chair. Real quick question. Do we have, based on the monoclonals available in our district, do we know the distribution of the brands? And the only reason I bring this up is some data came out yesterday showing that the GlaxoSmithKline will cover Omicron, as Omicron kind of takes over Delta here, most probably in the next month or two. GSK seems to cover just fine, but it would appear that Regeneron won't really cover Omicron that well. So I'm just wondering from, again, a public health perspective, that getting monoclonals on board really is effective, decreases hospitalization and death considerably, especially those first couple of, if you get them on board the first couple of days. Just want to make sure that we are prepared in our community with monoclonals that will actually cover the new variant as it starts to dominate. Thank you.
Madam Chair, it's Russ.
Yes, Russ, go ahead.
Yeah, Dr. Cole, great point. I appreciate you bringing that up. The Central District Health's role with the monoclonal antibodies has been just to facilitate the communication, coordination, establish the referral processes. As far as we connected Dr. Ryan Williams with the direct COVID care clinic on State Street with all the primary care providers that we have contacts with. But as far as the actual drugs themselves, that's all managed directly from the Department of Health and Welfare to all of the medical centers, including St. Al's, St. Luke's, and direct COVID care. But based on what you just described, we will certainly follow up with the Department of Health and Welfare, and our former earlier presenter, Dr. Christine Hahn, I know is very involved in that, and her team.
Thank you, Russ.
Any further questions or discussion points for Natalie? Okay, well, thank you, Natalie, for that report, and we will go ahead and proceed with our agenda to item number 6 under new business, which is a discussion and vote on our regular business meeting schedule. So, Russ?
Sure, thank you, Madam Chair. So December is when you set your schedule for the following calendar year. So we put a proposal together. It's the 2022 schedule. All of the regular meetings would start at 8:30. They would be held here at the main office with the option to join virtually, just like we have today. The May 20th meeting is when the budget hearing will also take place. So what we do with the budget hearing is we've rotated that around to each of our counties, and the board meeting follows immediately after the budget hearing. So this year it will be Boise County who will be hosting. We have traditionally done those at the Senior Center in Idaho City. And rather than start at 8:30, we start those at 10 o'clock just because of the travel that all of you have to do to get there. So this is a proposed schedule, certainly subject to change if things come up next year. It does also include our June 9th, which is the Idaho Association of Local Boards of Health annual meeting that Central District Health will host. And that will be an afternoon meeting, and it will also be virtual. So it's up
Madam
to you.
Chair.
Yes, Megan, go ahead.
Yeah, Madam Chair, and the only request I would make is if we could move the March meeting to the 18th, and then there's a better chance that I can actually make that in person.
Is that agreeable to the remainder of the board?
Yes. Madam Chair, it's Russ.
Yes, Russ.
I won't be available that day.
Madam Chair?
Yes, go ahead, Megan.
Could we push to the 25th, do you think, then?
The 4th?
Board members?
Yeah, what about the 4th, Megan? Since there's not a meeting.
I need to go. Yeah, I need to go later rather than earlier is the problem, because we'll still be in session and it gets really difficult to get on the call and also be on the floor of the House.
True, sorry.
Sure.
No worries. I'm trying to make it work.
Yeah.
25th works.
Does the 25th work for everybody?
Yep.
Okay. Let's go ahead then and put that on the tentative schedule, Russ, okay? The 25th?
Okay, and that requires a vote for you to adopt the schedule with that amendment.
And maybe
Yes.
change.
Madam Chair?
Yes.
Madam Chair, then this is Representative Blanks, and I'd make motion to change the March 11th meeting to the 25th of March.
Okay, thank you, Megan. Is there a second?
Second is Jane.
Okay, thank you, Jane. No further comments, I trust. We'll go ahead and take a vote by county.
Just some discussion real quick.
Yes.
Would it make sense then for us to also change the April meeting to the 22nd, so we don't have a meeting three weeks after the, I mean, it's not a big deal, but. Or is.
Yeah, Madam Chair, the timing is, that's the budget setting period. So we would be essentially presenting to the board in March. Here's our plan. Then the April meeting is when you would actually adopt the budget. And between the April meeting and the May 20th meeting, I come out and you're all certainly invited, if you're not a commissioner, to present the budget. So I think we could make it work on the 22nd, but those may be more brief meetings anyway.
Okay.
Kind of focus on the budget.
Then never mind.
Okay.
Yeah.
Okay.
All right. Any further comments about the changes? Well, hearing none, I'll call for a vote on changing that March meeting to occur on the 25th. Ada County, Dr. Young.
Jane Young, aye.
Raul Labrador.
Yes.
Dr. Cole.
Aye.
Commissioner Sturm. Representative Blanksma.
Blanksma, aye.
Valley County Commissioner Hasbrook.
Commissioner Hasbrook, aye.
Okay, motion passes with that schedule change.
Thank you, everyone, for being understanding.
Well, I'll bet you're hoping that you don't have to change that by the April meeting you're still not in session, huh?
Oh, you should all be hoping with me. Everyone should be hoping.
Right.
There till May.
Okay, so I guess we need to go ahead and approve the schedule then for the entire 2022, and I'll call for a motion on that.
Madam Chair, this is Al.
Yes, Al?
I'll make the motion that we approve the amended calendar for the rest of the meetings, and hopefully, as a side note, encourage everyone to start attending here instead of online.
Okay, noted. Thank you, Al. Any second to that motion?
Jane is a second.
Thank you, Jane. Any further discussion?
Is that part of your motion?
Okay, hearing none, we'll call for a vote by Ada County, Jane Young.
Young, aye.
Raul Labrador.
Aye.
Dr. Cole.
Aye.
Boise County Commissioner Sturm. Elmore County Representative Blanksma.
Blanksma, aye.
Valley County Commissioner Hasbrook.
Commissioner Hasbrook, aye.
Okay, thank you, folks. That schedule stands approved as presented then with amendments. Okay, moving on to budget revision ideas by Russ. Russ, go ahead and present your revision ideas.
Thank you, Madam Chair. And this one will be very brief since we added item number 8. So I was originally planning to build the Nurse Family Partnership Program into the budget revision that would be presented to you in January. But my preference is when we go to the next agenda item that we move money from our operational reserve funds, and I'll explain that a little bit more, to cover the expenses associated with getting Nurse Family Partnership launched for our 4 counties. So the budget revision ideas will be just the normal changes that always occur, and we make an adjustment mid-year. As a reminder, in May, when our county commissioners have that final say and final approval of our budgets, that's our plan. And then we get grants, some grants, and that we didn't anticipate. More recently, it's been more money coming in than we anticipate. So we'll make those adjustments for your approval at the January meeting, just so we're basically back on track with the changes that have occurred during the first half of the state fiscal year. So that's all I have. There is no need for a discussion and vote on this item.
So there is not a need for that today.
Madam Chair, this is all. I just have one question.
Yes, Elt.
In counties, we have to do a resolution to change budget mid-year. Do you have to do that here?
Madam Chair?
How's that done?
Yes, go ahead, Russ.
We do it by board vote, so it's not a resolution. We'll present the revised budget to you. Laurel will do that. We'll go through all the various changes that occurred, and then you will vote to approve the budget or not if there were concerns about that. Generally, it's just we're updating the budget. We're not necessarily planning to spend money that we didn't have. It's more money that comes into our budget or underspent or overspent, and we move money around within the budget. So that's all kind of line itemed out for you at the January meeting.
Okay.
Chair, this is Eld
All
again.
right.
Madam
Yes,
Chair,
Eld,
this
go
is
ahead.
Just for your own information, when counties do this, we have to advertise it in the paper for 2 weeks, and there's about a $600 charge for that newspaper ad. But the question I had for you, Russ, is I know we talked here a few years back about expanding the Parents as Teachers program. And is this going to take precedence over that?
Madam Chair?
Yes, go ahead, Russ.
So Commissioner Hasbrook's question was related to Parents as Teachers, which is also a home visiting program. And the differences are those are developmental specialists, more people who provide counseling services, versus Nurse Family Partnership is a bachelor's prepared registered nurse. So they are very different programs, serve different purposes, different risk factors in with the family. So Parents as Teachers has always been, when it started 4 or 5 years ago, is funded by a federal grant. The federal grant required that we only serve Ada County, and that changed recently. So we're able to provide those services out to Elmore Valley and Boise. I will say thanks to Representative Blanksman's efforts, we were able to get this covered by Medicaid. So Medicaid provides revenue also, and that happened very recently, so that we're not just providing the services with both state general fund, we have an appropriation, the federal money that we get through health and welfare under contract, plus we also now have revenue coming in from Medicaid to bill for those services. So Parents as Teachers is in a pretty good position. We don't offer Nurse Family Partnership because we've not had quite frankly, the money to do it. The state Department of Health and Welfare is part of that granting process. District 1 out of Coeur d'Alene and District 3 out of Caldwell, they have been allowed to use their funding for Nurse Family Partnership. So there's kind of a disconnect there, right? If you go across the county line, a family will qualify for Nurse Family Partnership, but they wouldn't here. So if you live here, you don't qualify. So that's on the next agenda item. That's why I'm going to be asking for the money.
I see where you're going.
Okay. All right. So no further action then today on item number 7. We move to 8. Is that correct, Russ?
That's correct.
Okay. Let's take up number 8.
Okay, what I am requesting today from the board is to move $200,000 of operational reserve funds, of which our current balance is $4,176,000. So to move $200,000 from operational reserve and place that under special projects. Laurel had covered that a bit earlier. So what the $200,000 would do is allow us to start recruiting, which, as noted earlier, is no easy task, and especially when you're trying to recruit bachelor's prepared registered nurses right at this time. But that is the plan. If you approve this today, we would hope to get it off the ground after we get the hires made. The nurses will have to go to training to be able to deliver the services to our community, and then we'll start providing those. And there is a revenue component to that as well that we'll be working on. So what happens after this one-time money, basically it's the launch money, is we already have a plan, if you approve this, so that we can sustain the program ongoing after July 1st. So we'll build this into our fiscal year 23 budget, which starts on July 1 of 2022. That will include billing revenue, the opioid settlement funds, and then we also have requests into Ada County specifically to use ARPA funds. And I have reached out to our other counties, but haven't heard back as far as if there's interest in helping support that. But I'm confident we can sustain it. It's just more a matter of we have money in our operating reserve account. We've never had as those of you who have been on the board, we were barely 1 month operating. And I'm going to try to be real brief with this, but basically the COVID funds for staff like myself, I billed a lot of my time, as an example, to the COVID funds, which reduced our indirect rate. So it reduced the demand on state and county money and really freed up this money, although it's one-time money, it's not ongoing. And I think this is an appropriate use and as a special project to allow us to launch Nurse Family Partnership. So my request is for the board's approval to move $200,000 from operating reserve into special projects for Nurse Family Partnership to cover January through June, although realistically, it's going to be late January, February by the time we are able to get people on board, get staff on board.
Madam Chair, this is El.
Yes, El, go ahead.
So what are you looking at? How many FTEs are we hiring? A lot of people?
So the program fully built out, which we're not planning to start with the full, like what you call it, a unit, is half-time RN supervisor and 4 bachelor's prepared registered nurses.
Half-time?
Half-time supervisors. So they would split their time.
Okay.
So that's what it is. Half-time supervisor.
Half-time nurse.
Registered nurse with 4 full-time registered nurses who are the ones that are delivering the services to families.
And you have those 4 now?
No.
So that's the goal long-term, and you end up with 5?
We're at 0 right now,
Okay.
so I'd like to get it started sooner rather than later, knowing we have the opioid money coming starting in April, and the minimum is $400,000 a year, depending on the local governments, if they transfer those funds to us, as well as future settlements that Idaho will be working on with other companies, distributors and manufacturers. So I think financially we're in a good position. We have the one-time funds right now, and I would like to invest at least a portion of those into getting us off the ground.
So would it be getting off?
Okay, Russ, this is Betty Ann. I'm curious to know how those FTEs would be apportioned out for county, to the 4 counties.
So what we would do is, like in Valley County, I would say that's probably the most challenging because of the drive time to get there. So what we've typically done, just like we're doing right now with Valley County, is we'll have a person who's working there, in this case, from the Department of Health and Welfare, who has another job, who has time to help us with infant and early childhood mental health versus trying to place a full-time bachelor's prepared registered nurse. Boise County is served out of Boise. In Elmore County, it really just depends on whether we're able to recruit somebody in the mountain home area to serve those communities. So our goal would be to make sure we have adequate coverage, depending on the referrals and the need for all 4 of our counties. I can't say it'll be exactly proportional to population. It'll really just depend on the referral network and how successful we are with that.
Okay.
Madam Chair, quick question.
Yes, go ahead.
Are you counting on the 200,000 covering 4.5 nurses?
Madam Chair?
Yes, Russ, go ahead.
So the 200,000 will just allow us to get started. So we're hoping to have 2 to 3 nurses on board, and it's only for about 5 months of the year. By the time we actually, I think realistically, like I mentioned, I think it'll probably be February timeframe. So we're going to start with Commissioner Hasbrook asked, well, what's a fully built out program? Well, it's probably going to be 2.5 registered nurses is what we're planning to start, and then build it up into fiscal year 23.
Awesome.
But I think your point's well taken. Like, I'm sure you're thinking $200,000, 4.5 nurses, good luck.
Yeah.
So
that was my
right, exactly.
Yeah. No, we're going to start at a smaller scale and then just build it out as we. because we're really starting at ground zero. We don't have our referral network. I mean, clearly the needs there, you all know that from children's mental health and parents, single parents, financial struggles, substance abuse, mental health, et cetera. Those are the families we'll be working with.
So Madam Chair, this is El.
Yes, El, go ahead.
I would like to make a motion that we authorize the use of operational reserve funds to implement the nurse family partnership to the tune of $200,000 the first year.
Move it into.
Okay, thank you. Is there a second to the motion?
Moving it into special projects added to that, and I'd second it.
Okay, any further discussion? Okay, we'll call for a vote by county. Dr. Young?
Young, aye.
Raul, Labrador?
Aye.
Dr. Cole?
Aye.
Boise County, Commissioner Sturm? Elmore County, Representative Blanksma?
Blanksma, aye.
Valley County, Commissioner Hasbrook?
Commissioner Hasbrook, aye.
Okay, thank you, folks, and that is a great move forward, I think, for our district. Okay, Russ, we want to move on to item number 9 on the County Commissioner Meeting Survey.
All right. So the board had asked me to reach out to our 12 county commissioners to assess their interest in getting together with this board and with staff to do kind of an informational session. And we heard back from 4 of the 12. 2 prefer not to do it. And of the other 2, we offered, would you like us to, if you wanted to participate in this kind of meeting, would you like to come to Boise and be part of like a board meeting, or would you like us to come to your county? So 2 of the 12 said they would like to participate. 1 would like to come to Boise to a regular board meeting, and 1 would like us to come to their county. So in conclusion, I would suggest it we not spend a lot of time putting that together.
Discussion?
Well, I think it's great that you at least canvass them and see how they felt. If they're not interested, they're not interested.
Yeah. Yeah, unfortunately, I agree, Else. So.
Thank you.
Okay. If there's no more to be said about that item, we will move down to the director's report.
All right, this should be relatively quick as well. I just wanted to provide you an update on the implementation of House Bill 316. Just as a reminder, that was passed this the legislative session of 2021, signed into law by the governor. It did 2 things. One was it shifted the funding starting March 1st to 2022. That's the effective date of the bill, from state general fund that went to the health districts to that portion will now be covered by the counties. The expectation is the counties will cover that with the medically indigent fund, the taxes they collect for that. For our 4 counties, looking at what is collected in revenue versus what's being the much smaller amount that's being spent on the medically indigent services, all 4 of our counties would end up well in the black if they continue to tax at the same rate and use that money to fund the health district. So and what caused that was Medicaid expansion. So individuals who previously would go to the hospital, go to the counties, it was at first $11,000 the counties had to pay for the claims. That was, I'd say, greatly reduced. So starting March 1st, the counties will be responsible for basically 40% of our budget instead of 20%, because the 20% coming in from the state will go away. But there was some other provisions that we actually worked on, which was to get clarification in law that the public health districts aren't state employees. We're not to be treated like state employees. Really, it was emphasized in specific language, and I will tell you it's clarification language because, as you all know, since 1970, it has clearly stated we're not departments of the state. We are independent bodies, corporate politic, and we report to boards of health who are appointed by county commissioners. So we're not county agencies, we're not state agencies. So the clarification language went into effect. Where this is going now is in the State Division of Human Resources was where the biggest impact would be. We could have transitioned into becoming what they call non-classified employees, which are essentially at-will employees, but still be part of the state system. But the State Division of Human Resources essentially is taking a position, if you're not a state employee, then you're not going to be under the state personnel system at all, period. So you either would work to change the language back and say they control all salary decisions, all position decisions, all reclass decisions, or you're on your own. So that's something that, quite frankly, we don't have a problem with. We're very capable of doing our own personnel management system. We have it's called Working at CDH handbook, and that will be presented to you for your approval in January. So it's actually ready to go, but I didn't want to put that on the agenda today. I want to make sure you have time to review it. So all of our employees will transition to at-will employees, which is basically what most employers are in the state of Idaho, with exceptional protections provided by the state personnel system. And I can explain that a little bit more detail now, or probably more appropriately in January. There's one other change. State Risk Management has made a determination that they can no longer provide coverage for us. That's all your liability coverage, because we're not state employees. I did talk to their director and said, well, truth is we were never state employees. Nothing has changed. We've had a memorandum of agreement in place with State Department of Administration since 1977. Maybe even prior to that, but that's as far back as I could find, where they had agreed to provide the services knowing that we were not state agencies. So big deal, probably not. We're looking at using ICRIMP, which I know the counties use, and from what I've heard, they provide exceptional services. Heard no negative. So we're in the process of exploring that. And when I say we, it's all 7 public health districts. So I think that should go smoothly. Probably the only issue would be if the cost was substantially more to go to ICRIMP, then we may want to come back and look at a legislative solution to have us described in Idaho code as being allowed to be covered by, or authorized to be covered by, State Risk Management. So that's what I have for you. It's more of an update. Everything else is rolling forward. We're members of participants in Percy. State Controller's Office will still be using their services for all of our accounting and payroll. Brandon Wolf will still sign our paychecks. Our health insurance, Office of Group Insurance, will continue. Our relationship with Health and Welfare and DEQ will be maintained through MOUs versus the delegation of authority that they previously had, that was taken out of Title 39, Chapter 4. So I'm going to stop there because I know it's getting long in the day, the morning, and I will be presenting to you the Working at CDH Employee Handbook at the January meeting for your approval, and I'll get that out to you soon so you have time to look at it. I'm open to answer any questions you have.
Madam Chair, this is Al. I just had a couple of comments and a question.
Yes, Al, go ahead.
One thing you got to realize is that when we did the 316 bill, and we got all done, we realized that we didn't have any kind of coverage for illegal folks in your counties. So a bunch of folks come up to work at a ski resort or work in the farm fields. If they're not J1s, I think they're called, you're still going to have indigent costs that come into the county. So I would imagine there's still going to be a full levy for that indigent account until we kind of see where that floats out. The second thing I think that we should really sit down and discuss as 7 districts is maybe to try and get in under the GEM plan insurance program, which is a Blue Cross that almost all the counties are using now. It's phenomenal insurance, and we didn't get a rate increase at all last year. So that may be something for the future to talk about, Russ, for everybody going to GEM plan. And then I was trying to think of the third point. Oh, the employee handbook. Those are more important than people give them credit for. Like the counties know, what most of them are doing is they read each policy and each employee signs it. We're finding out that when we go to court for a termination hearing or a lawsuit, if we have that documentation, it's taking care of a lot of our liability issues. And so we have an onboarding process it's almost a day-long process for new employees to go through and read all this and sign it. So those are really important, and they're updated all the time. So,
Madam Chair.
Yes, Russ, go ahead.
So Commissioner Hasbrook's point's well taken. We do have a plan. We already have an acknowledgement form that you received and you've read the employee handbook, and then we have processes in place to make sure that there's notification and acknowledgement for any changes, because as you know, handbooks change. So that's the plan.
Good.
And I'll share that with you when I send out the handbook.
Good. And for those guys that didn't show up today, you don't get any honey. Sorry.
Hey, you were eating Fritos up in Cascade at our last meeting while we were in Boise.
Get paid to begin with, Elf. I don't get paid anyway.
Well, I can leave it here, but I'm not going to guarantee it'll stay here very long.
Donna, you're in charge of keeping track of our honey. Okay, anything further, folks?
Just something real quick. Russ sent us all the article that I talked about. I'd like to discuss it a little bit more at the next meeting, but I thank you for sending it to everybody.
Sure.
All right.
Okay. Well, thank you for your participation, everybody. And at this point, I'd just like to wish everybody a joyous and merry holiday season. And hopefully we're going to have a healthy new year coming up. And at this point, I'll ask for a motion for adjournment.
I move to adjourn.
Second.
Second. Okay. I'm sure there's no more discussion on that issue, so we'll call for a vote. Dr. Young?
Aye.
Raul Labrador?
Aye.
Dr. Cole?
Aye.
Boise County, Ryan Sturm? Elmore County, Representative Blanksma? Valley County, Commissioner Hasbrook?
Aye.
Okay, thank you, folks, and enjoy the rest of your day. Safe travels home for those who are at the meeting place there in Boise. So,
thank you. Merry Christmas.
That concludes our meeting today. Thank you.
So